Good morning, everyone. I am Kamal Narayan, CEO of Integrated Health and Wellbeing Council, India's premier institution for health awareness, advocacy, and behavior change. And I am immensely pleased to welcome you all to this inaugural edition of Kidney Health Summit 2023. This timely and critical initiative aims to address challenges posed by the growing burden of kidney diseases that inflict immense suffering on millions. And we are thankful that responsible pharmaceutical and healthcare organizations such as Dr. Reddy's Laboratories and Apollo Hospitals have come forward to support this summit. We at IHW Council believe that health is a non-negotiable aspect of human prosperity and happiness. We work towards creating a better and healthy world through various endeavors aimed at mass awareness and facilitating favorable and empathetic policies. The pandemic made all of us realize that our healthcare system needs to be well equipped for crisis management. And this becomes all the more critical for issues such as kidney diseases, where any disruption of care can prove fatal. This is also the message and theme of this year's World Kidney Day, which encouraged the healthcare planners to prepare for unexpected and exigencies and supporting the vulnerable. Studies have estimated that over 1 lakh patients are diagnosed with end-stage kidney diseases in India every year, and most of them belong to the economically and socially weaker section. But due to lack of accurate national data collection, we can confidently say that the above number grossly underestimates our country's actual burden of kidney disease. What may be making the matter worse for kidney disease prevalence here are glaring inequalities in access to healthcare between urban and rural populations, disparities in wealth and literacy, and above all, the rapidly growing number of hypertension, diabetes, and obesity patients. Also, CKD management in India is hampered by low awareness about the disease and the high and recurring cost of dialysis, which proves to be a significant financial setback for patients and families, most of them having no insurance coverage to fall back on. Though the government has initiated some highly impactful schemes, such as Pradhan Mantri National Dialysis Program under National Health Mission, to strengthen the dialysis infrastructure to all districts of India to ensure easy and quality service access to patients in need. Similarly, globally appreciated government-funded health insurance scheme Ayushman Bharat has also become a significant relief for poor patients, saving them from catastrophic medical expenses. But while we still have to go a long way to fill all care gaps, we must create awareness of preventive aspect of the disease. Chronic kidney disease onset and progression are often preventable through primary, secondary care. Healthier lifestyle changes like reducing the use of tobacco, alcohol, following a non-inflammatory diet, controlling the intake of salt and sugar, and leading a non-sedentary lifestyle are some of the major and sustainable changes that can help in this regard. Remember, when it comes to kidney ailments, prevention is indeed better than cure. However, it is equally essential to ensure a supporting and enabling environment for chronic kidney patients as well as their caregivers, and at the same time ensure that kidney care is accessible and affordable and leaves no one behind, even in times of emergencies such as pandemic, flood, or even war. So with this firm resolve, let's commence the opening session of today's summit to understand current challenges and way forward for chronic kidney disease in our country. And for this session, we are privileged to have with us Dr. Professor A.K. Bhalla, Chairman and HOD of Department of Nephrology at prestigious Sri Gangaram Hospital, New Delhi. He is a pioneer in developing peritoneal dialysis as a modality for renal replacement therapy in India. Dr. Sanjeev Jasuja will be joining in the next session. We also have Dr. Urvashi Prasad. She is presently engaged as Director Office of the Vice Chairman of Niti Aayog, the apex policy think tank for Government of India. Ms. Prasad holds extensive experience in health, nutrition, sanitation, gender and public policy, and SDG. We are also privileged to have with us Mr. Amitabh Banerjee, Director and Division Head of Nephrology and Critical Care at Dr. Reddy's lab. And also we have with us Dr. Manisha Sahai, HOD of Nephrology, Osmania General Hospital and Osmania Medical College, Hyderabad, and Assistant Editor of Indian Journal of Nephrology. So thank you everyone for joining on this inaugural session of Kidney Health Summit hosted by IHW Council and supported by Dr. Reddy's and Apollo Hospitals. Let me begin with Dr. Bhalla, because Dr. Bhalla is also traveling. So I want that before he gets, kind of out of internet coverage, we, get some inputs from his side. Dr. Bhalla, you are with us?
Yes, sure.
So Dr. Bhalla, from the clinician's point of view, you have been, helping, serving, and kind of managing CKD for very long. I would like to understand first that, in terms of what is the state of affair when it comes to, diagnostic prevalence, so that it kind of helps us build the dialogue. What are the challenges we see in kind of managing and addressing this problem?
As you have said, the kidney health for all, and like we have the theme for this World Kidney Day, supporting the world. So when we are saying we have to prepare ourselves for the unexpected. That's what we actually saw during COVID times, when we have difficulty in giving dialysis to the patients who are dialysis. Then patient travel to dialysis, and then patient had problems with the transplant program was stopped. So all this actually have to prepare for the
Dr. Bhalla, I think because internet is not proving to be that robust. So if you may switch off your video, we can get a clear voice from your side.
Okay.
Yes.
Sure. So one is the right earthquake, pandemic, you have a disease and causing ATI, various causing muscle network and ATI. So to prepare for that. Second is supporting the vulnerable. Huge vulnerable population. One cause of CKD is diabetes, for hypertension. Then we hereditary diseases, disease, especially in North. Then again is now becoming as a very, and already 20 to 25% population is obesity. Plus have various environmental factors like air pollution, then water toxins. So the environmental factor also have to support this vulnerable. So major three groups: obesity, hypertension, and
Dr. Bhalla, your voice is not kind of consistent. So let me go to Dr. Manisha Sahai in between, and we will
three tests.
Yeah, sir, right. We will reconnect with you if you can hear me.
Yes. I can hear you.
Yeah, sir, actually your voice is not coming clear. So I'm then kind of inviting Dr. Manisha Sahai to kind of help us understand the points which you are highlighting, but because of, I think, internet problem, we are not getting the consistent voice, which may not help our audience also to, kind of understand. So Dr. Manisha Sahai, if you may kind of explain what Dr. Bhalla is trying to convey, about the various diseases or kind of NCDs, which are adding to the, additional burden of kidney diseases, and what are the other factors, and how, kind of the whole prognosis is going on.
Yeah, so thank you for that question. And at the outset, thank you, Dr. Reddy's, for this very nice initiative, which is going to have a far reach. And my respects to Dr. Bhalla and Dr. Jasuja, the senior people on the call. So as Dr. Bhalla has clearly highlighted, see, in India, the awareness of kidney problems itself is poor. Diabetes affects around, do you know how much percentage? Around 18 to 20% of our population. And hypertension affects around 25%. If you ask about kidney diseases, people say, are they common at all? Why such seminars? Are they common? Remember, kidney diseases, they affect the chronic kidney disease, kidney failure. It affects around 17 to 18% of our population. So it's not far behind diabetes or hypertension. And still, sadly, we don't do anything about it. We are not aware about it. Now, why is this happening? So remember that the major problems, the major causes of kidney disease, which you asked and Dr. Bhalla was highlighting, number one still remains diabetes. The second one, apart from, hypertension is another important cause in our country. The third important cause is a surprising cause. It's CKD of unknown etiology, which is supposed to have many factors responsible, maybe because of heat stress, because of pesticides, because of water contaminants, because of air pollution, because of dehydration. So can you imagine CKD of undetermined origin, where we are presuming all these causes, is becoming an important cause of kidney failure in our country. And many of the people take unlicensed, I put quote unquote, unlicensed indigenous medicines without any prescription. So they add to the burden. So this is called CKD of undetermined etiology. So these three, diabetes, hypertension, and CKD of undetermined etiology, are the major causes. But there is something more. Obesity, that's the major disease nowadays, what we are facing, an obesity pandemic. About 1/3 of our population is malnourished, but another third of our population is overnourished. Obesity. So this is very, very important. And obesity we call a lifestyle disease, a non-communicable disease, a man-made disease. So diabetes, hypertension are also related to obesity. So obesity, sedentary lifestyle, lack of sleep, excess of stress, all of that also lead in some way or the other to obesity-related kidney diseases. So these are the major drivers of kidney disease in our country. Some of them are eminently preventable, but the problem is awareness itself is not there. We don't know that this is the cause, and I am also responsible for my health, and I am the person who's contributing to kidney disease. So apart from these, you have other factors in India. India being a hot country, we have stones which are very common because people simply forget to drink water. So all of us need to drink 8 glasses of water per day. But do we do it? We forget to drink water. In addition, in India, you can never forget the infections. So all those infections, if properly treated, fine, they recover. In case you do not treat them properly, they may lead to kidney disease. And last but not the least, even pregnancy-related kidney diseases are common in India. And why that happens? Because of unbooked pregnancies. So some pregnancies, deliveries occur at home. I'm not saying that's wrong, but there should be proper follow-up. The blood pressure of the woman should be monitored during pregnancy. So this is very, very important. And there are many other causes, but these are the 5-6 major causes of kidney disease in our country, which is as common as diabetes and hypertension. We all know about diabetes and hypertension, but you ask general population, kidney, where are they? What do they do? Does kidney disease exist? Why this webinar? Those are the questions we get, and this definitely needs to change.
Thank you so much, Dr. Sahai. A very important point, and the kind of causes known and unknown both you have highlighted. In country like ours, definitely we have, I think, all these causes extremely prevalent, which leads to higher burden of kidney diseases. So let me, kind of go to Urvashi Prasad ji. Urvashi ji, as I was mentioning, government has definitely tried to bring in a lot of, support system, right from Ayushman Bharat to, the scheme started by Pradhan Mantri to kind of put together dialysis centers, almost every state, kind of districts of our country, through even PPP model. While this is a very welcome step, helps patients who have already gone into the, kind of a stage where this, kind of support is needed, and it is being needed by, the number says almost 2.2 lakh or more than that patients are diagnosed with in end stage renal diseases, or disease of every year, which leads to almost 3.5 crore of dialysis, cycles needed every year. When you look at it, and also seeing that the causes which Dr. Sahai and Dr. Bhalla identified and highlighted, we have massive prevalence of that. While we are looking at addressing at the tertiary level or as a dialysis level or as a, advanced stage, how do you see we can kind of formulate and strengthen our policy at a screening level of kidney health, so that people who have high risk, especially diabetic and especially people living with hypertension, which is very prevalent, do not develop advanced stage of kidney diseases, and we can kind of diagnose, screen, or prevent at very early.
Yeah, first of all, thank you, Kamalji, for having me here. I think, before I speak about the treatment end of things, or, what we're trying to do there, as you said, a lot of our focus now is actually on the prevention, on the early detection part. And especially, two aspects there that I would highlight. One is, like we are saying, that the most prevalent, common risk factors in a way for developing chronic kidney disease are lifestyle conditions, like hypertension, like diabetes. And this is especially so when these conditions go unchecked for a long period of time. People continue to have uncontrolled hypertension. People continue to have uncontrolled, diabetes. It's only after a long period of time that they actually realize that, they even have these conditions. And by that time, even critical organs like the kidney have probably already suffered a fair bit of damage. So one of the things we are focused on, through initiatives like the health and wellness centers, which also come under Ayushman Bharat, but also other channels, is that we want to firstly pick up such people early, whether they are hypertensives, whether they are diabetics, so people who are at risk of, developing these kind of conditions and having damage to some of their critical organs, like the kidneys. So that is, I think, one very important emphasis, because unless you identify such people early, you really cannot, sort of prevent or minimize progression to a more advanced, stage of disease, including kidney disease. So that is one dimension of it. The other aspect that, we are focusing on is building capacity of health workers, health professionals across the ecosystem, like this two panelists, also emphasize that you might actually come to the doctor for a very different condition. You might come for pregnancy, you might come because you've had COVID, right? We are seeing so many people developing kidney complications, part of what we are calling long COVID increasingly, right? So I might go to a health system with a very different problem. But actually, one consequence of that, or one related, consequence of that disease or that underlying condition might be damage to my kidney, which I actually am not able to, even understand or comprehend that is possible. So we need to build also capacity of different types of health workers, people who are not specialists in this condition, but at least for them to be able to pick up and identify that a kidney complication is possible here, and this person should at least be screened for that, or this person should be possibly sent to somebody who's a specialist who can check him or her for this condition. So that is the other area we are focusing on, because not everyone with a kidney issue will land up at a specialist, and that's not even desirable, and that doesn't happen. I can go to any level of the health system, I can go to any type of health provider, but they must be alert to this. They must be alert to the fact that this is a very real and possible complication. So that is the other part of focus that we are trying to bring on the policy side. And then, of course, as you said, that there is the treatment end of things. People who do unfortunately develop more advanced disease, who do need that kind of support. We are definitely trying to strengthen the dialysis program. We're also, now trying to work on the organ transplant, which is, of course, something you will need only, at a very, very advanced stage. And, literally when you're, you have a kidney failure. But that is also a demand which is, very high and fairly high in our country, and it's an unmet demand. So we are actually trying to work on a one nation, one policy for organ transplant, which will, of course, be for all types of, organ transplants, but also kidneys, and kidneys is a very important part of it. So that, of course, we are working, at the tertiary end of things, at the treatment end of things, at the advanced end of things. But as I said, the bulk of our focus is actually, on the prevention, early detection, because we want to try and identify people as early as possible. We don't want to wait for them to, actually reach that level. So, yeah, so I think that is, what we're really trying to do on the policy side.
Thank you so much, Urvashi ji. I think a very important aspect of is definitely that what the government is also trying to look into the prevention as a more important area than kind of looking at cure only, because by preventing, not only we are able to save essential resources for both the government and even those who are kind of paying out of pocket, but also kind of protecting them from a lot of suffering which goes on individual level, on a family level, or societal level as well. You very aptly highlighted about identifying early, and where the system need to be strengthened. As you said, that if you are going for any other kind of ailment to the healthcare system, the system should be able to pick up early signs of these diseases as well. But at the same time, it is also the individual responsibility, to be more careful and to be more aware about their health. And that's where the whole aspect of kind of enhancing awareness at, kind of mass level, society level are important. So let me go to Mr. Amitabh Banerjee. Amitabh ji, role of awareness in kind of identifying or screening or diagnosing these diseases early or preventing them is very, very critical. How companies like yours are, kind of looking into empowering the larger population in this direction?
Thank you, Mr. Kamal. And I would at the outset like to thank all the experts, all the dignitaries from government as well as the nephrology fraternity for making this program a success. We have just begun this. I'm sure the day-long discussions will be bringing a lot of new things in the minds of everybody. More than that, actually, I would like to also take you through the little understanding what we could able to get when I joined this nephrology fraternity a few years back. We could able to understand that the problem is in the primary level of screening and diagnosing. Many a time, the physicians who are the primary custodian of the diabetic or hypertension patients, they don't give that much of importance to the kidney disease, or their awareness level were low. I would like to thank the Indian Society of Nephrology. Manisha ma'am is here. She has also contributed a lot, and the other dignitaries from the Indian Society of Nephrology. We could able to develop a modules called Physicians Academy for CKD Educations from the ISN. And we took the opportunity to create awareness among the physicians, because they are the primary, as Madam Urvasi was also trying to talk about it, that the physicians, when they are diagnosing, many a time they look for the HB1C, or they look for the hypertension, lipid profile, etc. But most of them, they miss the GFR or hemoglobin, and then these patients progress to kidney disease faster. So creating awareness at the physicians level was the prime thing that we felt. And last year, I am happy to say that more than 132 nephrologists supported the cause, offline and online. We could able to create and reach to more than 2 lakhs physicians in the country. So this is how we have taken this initiative for creating awareness, apart from social media, mass awareness at the various levels in the populations. But more importantly, the physicians, who are the primary physicians who treat the hypertension, diabetes, and all these things. And they should be knowing more about kidney disease. They should be aware about stones and everything related to kidney, such that they can refer the patients to the center of excellence or the experts on time. And that is what the mission that with which we are working and creating the awareness. So that is one important thing. Second thing is also important, as Dr. Bhalla is here, Madam is here, and they are the pioneer in home-based dialysis. So that is also another thing. We believe that in the coming days, apart from causing the infrastructure for hemodialysis, if the patients from far-flung areas can get the dialysis on a home-based thing like that of CAPD and peritoneal dialysis kind of thing, I believe that more patients will be having a better quality of life, better healthy life. Of course, the experts will decide upon it, but there are certain advantage of this, which we will try to create the advocacies for those kind of patients also. So this is the primary thing. As a pharmaceutical responsible corporate, we are trying to create awareness on the physicians and the mass level for kidney disease. Thank you.
Thank you, Amitabh. Definitely, it's a very, I think, important step which you have taken, and also the, ISN has taken in terms of setting up this Physicians Academy for CKD, education, because I think training 2 lakh physicians to pick up these signs early is definitely going to, help a long way in terms of overall management and kind of reducing or preventing, kind of advanced stages of kidney disease. Urvasi ji, let me just come back to you once again. This is very important, and you have also mentioned about the same thing, that we need to kind of train and educate and even do the capacity building of healthcare workers who are non-specialized for kidney care or nephrology, and what Amitabh ji just mentioned is definitely a very, very important and step on that side, that line. When it comes to even a specialized, workforce for kidney care, and that, as we have already kind of mentioned, the big numbers which we see in our country, there are, the numbers say there are only 2,600 nephrologists in our country at present, which comes around maybe one nephrologist for nearly 10 lakh people. And seeing the prevalence of diabetes, and seeing the prevalence of hypertension, and understanding that they many time or often lead to kidney diseases, and also seeing, as Dr. Sahai and Dr. Bhalla both highlighted, that around 17% of population may be or is kind of having kidney disease or can have kidney disease. How do you see also looking at in terms of strengthening the skilled professionals also for this kind of disease, along with while we build this capacity of non-specialized, how we also add on the specialized workforce for this?
Yeah, no, I mean, I think there's no doubt that, Kamalji, we need more specialists, and we need a more equitable distribution of specialists, because of course there's also a lot of regional inequities, and there's also a rural-urban challenge. So this is true for actually most categories of specialists, that we are dealing with, and very true for nephrologists also. So nephrology, for us is a very, very important category of specialization that we are trying to increase both the quantity and the quality. So we are investing in both quantity and quality of that skilled workforce. There's a careful look that is going into even the curriculum, to say that are we adequately covering not just basic nephrology issues, but like I said, the emerging issues, like I just mentioned COVID, and long COVID as an example. It's a very emerging issue. We don't know fully even, where all this will lead to, but there are patients, who are coming up with these complications. So we are trying to also make sure that our curriculum, of course, we need more nephrologists. The quantity needs to go up, and their distribution needs to go up, but also the quality, and making sure that the curriculum is keeping pace, with what is happening in the overall healthcare ecosystem, because I think that is very important. A lot of times what happens is that we look at specialities very individually and in isolation, that this is cardiology, this is nephrology, and of course you have to go deep into a subject, you have to do that, but the curriculum also has to be very cognizant of the links between all of this. And that's what we said. If I'm somebody looking at diabetes, or if I'm dealing with an obese patient, I have to be fully cognizant and aware of all the interlinkages and possible complications of a particular condition that somebody might have, so, or a particular risk factor that they might have. So I think there's a lot of efforts going at the curriculum level as well, and this is, again, like I said, this is for every level of the health system that we're doing it. Of course we are focusing on the specialists, of course we are focusing on that end, but in a large country like India, you really cannot afford to sort of leave everything to that highly specialized level. You can't increase the burden on them, that every patient lands up at their doorstep. You have to try and intervene at a much earlier stage, and so even if it's a health worker at a health and wellness center, we are saying that even he or she should be aware that a patient might come with this issue. Yes, we are not expecting that he or she will be able to fully diagnose or treat or prescribe medicines. No, we are not expecting that, but he or she should at least have the ability to pick it up and say that, okay, I think this can concern with this patient, because that is our best bet. In such a large country, if we put all our efforts into the other end, highly specialized end, then I think we will just create a very, very skewed system, which like you also say, very expensive, and very costly, just in terms of societal implications, economic, financial implications. So I think it's no doubt, it's not that it's one or the other. We have to do both. It has to run on both tracks. But what I'm trying to say is that we are trying to put a greater part of focus on the more early stage screening, detection, identification, and even looking at our curriculum, our training, our capacity building at that stage, to say that how do we become more proactive rather than reactive, and only deal with somebody who is coming at a more advanced stage. So it's just the balance that I think we are trying to shift, but there's no doubt that we are working on certainly both those tracks.
Absolutely. I think the key here is that how all of us, including the government and the system, can become more proactive than reactive when it comes to addressing any health issue. Dr. Bhalla, I think, Dr. Bhalla, are you in a
Yes,
better zone in terms of,
yes,
okay, yeah. So,
yes, yes.
I will request, without opening maybe your video, you can help us, kind of hear your views also. So Dr. Bhalla, you heard about, and you also, kind of at the very beginning started saying that how multiple, causes are contributing to it, and we have understood, kind of trying to understand from Dr. Sahai also talked about and elaborated it that, there are known, unknown, all causes, and in a very heavy prevalence. Urvasi has been, kind of highlighting how the government is looking at, the preventive, the early, screening, early pickup of these diseases, so that we can, kind of reduce the burden on the super specialized level of care, and can prevent the prognosis of the disease. What's your view on all of that, and how do you see that? What are the key areas we need to work, both from the system side as well as the, the patient side?
See, there are, as you said, that there are about 2,500 nephrologists in the country, and you cannot leave this job to the nephrologist. So you have to do early detection, screening, and prevention of the CTD. And how to approach it, the most important thing, I think, which we have not highlighted yet, is urine examination. Urine ACR, that means urine albumin creatinine ratio, or microalbuminuria in a diabetic patient, or simple urine protein examination, a very simple and cheap test. So urine examination, serum creatinine value, and of course blood pressure recording, and if possible ultrasound of kidneys. These 4 simple tests do not cost much, but in large population we can do early screening and detection of CTD. So all vulnerable population like diabetes, hypertension, obesity, and that is how we have to approach. So early screening and detection, just make a small kit, do urine ACR, creatinine, calculate EGFR, do a BP recording, and if possible ultrasound of kidneys. That is what has to be done at district level. Now, according to Prime Minister dialysis mission program, there are 740 districts in the country, and we are having 740 hemodialysis centers. But our main focus has to be on early detection and then prevention of CTD. That is how I will approach it. And in last year, when I was president of ISN, I had a program with pharmaceutical companies, and we made modules, and we trained more than 1 lakh physicians, and we organized these modules, and that's how we did early screening and detection. That's how Dr. Reddy's is also has done, and it will continue. I think ultimately pharma industry, government, and our society of nephrology, we all should work together for this. Our aim should be early detection and prevention of CTD.
Wonderful. Thank you so much, Dr. Bhalla. I think you have highlighted very important aspect. Nowadays, when we are seeing, and especially, that set of population, which is apparently relatively more concerned, conscious, and aware about their health, people are going for even, especially the diabetic and people who have hypertension or have some, set type of NCD, and which are more prevalent ones. They keep, going for preventive tests sometime, and even, generally going for CBC or blood test. But going for urine test regularly,
yes,
has not been, I think, some a very visible practice if we see. And I think
yes.
very high important point that while we have become more aware and receptive in terms of and more open to go for blood tests quite frequently, urine test should also become part of that, to kind of have a check on kidney health and the other aspects also, which we can get from the urine examinations as well. Dr. Sahai, IHW Council focus a lot on women's health also, and last week only with the FOGSI, the Federation of Gynecologists and Obstetricians, we initiated a whole campaign and movement about preventing and managing NCDs among women, and kind of exhorting the society from, and even the government and the system from kind of awareness to action. When it comes to NCDs, we have seen that women are more vulnerable, maybe kind of the other predispositions are also higher among women. How do you see kidney disease burden also from this perspective, and how much the burden of, or how much burden is being shared by women, where the disparity or inequality for care, access, priorities are relatively lesser. Disparities are higher, priorities are lesser.
Fine. So that's a very good question. And for just to inform you that we celebrated the Women's Day 8th March, and we had a World Kidney Day also the same week. And now we have a society, the Women in Nephrology India, WIN India, and it's working closely with Indian Society of Nephrology, and ISN has been very supportive of all the women initiatives, and they have also looked at women-related issues. Now, having said that, do the disparities exist? Yes, I definitely believe so. The prevalence of CKD in men and women is almost similar. However, if you look at the percentage of women undergoing dialysis in all these centers, we have a similar government-funded center in our hospital as well. So it's a sad 25 to 30% only. Around 70 to 75% patients on dialysis are men. So where are the women going? That's first step. The second thing is, even if you look at the footfall in OP, the women come very less frequently for their health checkups. Most of the times, either they accompany their male counterparts as attendants. And again, the footfall is very low, though the prevalence seems similar. The third important disparity, a starking, glaring disparity in our country, is the scene of organ donation. As Urvashi ma'am was highlighting, organ donation, we do around, say, 15,000 kidney transplants in our country every year. This includes both live donor transplants and the transplants from deceased donors or dead donors. And you'll be surprised what percentage of these kidney recipients are women? Just a paltry 20 to 30%. All the predominant recipients of kidneys are men. And who are the donors? Again, no surprises there. It's women. So 80 to 90% of donors in our country are women. And who are these women? Either mothers or spouses. Mostly wives are the default donors. So I think, fine, many of the times the donation by women is altruistic. They want to support their husband, maybe their brothers. They want to support because they are the breadwinners. So altruistic donation, fine. But women should not be forced to donate. They should not be coerced into donation. So it should be a voluntary donation. So this is the scenario. Great disparity between the recipients and the donors. Another important point which makes women different is the pregnancy. So pregnancy is unique to women. Pregnancy and motherhood is the essence of womanhood, so as to speak. And as I highlighted in my opening comment as well, unfortunately, one of the major causes of kidney diseases in India, which is very less seen in the Western world, is pregnancy-related kidney failure. You'll be surprised to know a young female, recently married, gets pregnant, there is happiness in the family, but because of unmonitored pregnancy, because of hypertension during pregnancy, she ends up getting a disease called preeclampsia, and many of the times she loses the baby, or even if the baby survives, it's born with a very low birth weight, and many of the times the woman goes into permanent kidney failure. A normal, healthy woman, wife, mother, single pregnancy, unmonitored with the complications, goes into cortical necrosis. The kidneys completely die and she goes into a lifelong of dialysis. Either she dies or goes for a lifelong dialysis. So this is the most horrible thing which a woman can face if the pregnancy is unmonitored. And pregnancy is, as we all know, unique to women. So this also needs to be looked at, and this pregnancy-related acute kidney injury should come down. Now, another important challenge in women is women are mostly homemakers. They stay at home. They don't go for any sort of physical activity. The lifestyles are completely sedentary. At least I am happy to see that there is some shift in the mindset, and we see population coming to gyms and all, but many of them are males. Women, still, they are on the back foot here. And what do is they do not concentrate on their health, the type of food they are having. We are all talking about the lifestyle and also the diet, but we should be more precise in educating the public, the women especially, about what diet. They do not take breakfast properly, eat the leftovers. This should not be done. And we should educate, in fact, not only the women. If we educate the women, you educate the family. So concentrating on diet also is important. We were talking about prevention of kidney disease, and prevention apart from early screening, which can be done by everyone. Counseling about diet is important. Salt, half teaspoon per day if you are hypertensive. Stop white in your diet. Stop maida. Stop sugar. Oil, half liter per person per month. Water, 8 glasses per day. Go from white carbohydrates to brown carbohydrates. Shift from white rice to brown rice. And apart from that, let your diet be purely vegetarian. At least leave the red meat. So all these messages should be given to the woman who will improve her health and in the process improve the health of the family as well. So all these points are very, very important. That's why I say that women have special challenges as far as the kidney is concerned. They are default donors. They have pregnancy to take care of. And in addition, they are the caregivers for the family and need to be educated as well. Focus on exercise should also be inculcated in them from a very young age. So we were discussing on whom to screen, how to screen, who should screen. So who should screen? Urvashi Madam showed very clearly, everybody should screen. So we should have 10 commandments. We are talking about all these things, but still I am so unhappy as a nephrologist to see patients coming to me at the end stage kidney disease. They are not diagnosed. They are 10 years diabetic, 15 years diabetic, not a single value of creatinine. So how do we implement what we are taking for the women as well? So I think the screening should be done at all ends, even by the gynecologist when she sees the woman, by physician, by practitioner, anybody. 2 simple tests, the urine albumin and the creatinine GFR. Who should do, what should be done, and whom should be screened? So ma'am pointed out diabetics, hypertensives. We have all these dialysis centers. There you have dialysis patients coming with their attendants. The attendants also are at high risk because they have a family member with kidney disease. So they are the ideal catch points where you can have a screening clinic next to your dialysis clinic. All the dialysis centers which government has opened, Honorable Prime Minister, wonderful job for 1.3 billion people which are benefiting the poor. We can use these centers in multifold ways. They can be centers for screening. They can be centers for counseling, for organ transplantation. They could become the hub centers and the spoke center, hub and spoke model for even telling them about the preventive programs of kidney disease. So I think that should be the way to go. We should give easy 10 commandments for everyone to follow, be it a healthcare worker, a medical worker, a non-medical worker, because 10 things. Do this, 1, 2, 3, 4, 5. So because it's important to pick up the kidney disease early. I'll just end by saying one point. In India, we are doing a mammoth job of having so many dialysis, dialyzing 1.3 billion people, providing dialysis to all CKD among them is a huge job. No country has ever done it. I really congratulate the government for that. But important thing is, apart from using up a lot of money, somebody is paying. If not the patient, the government is paying. The second important thing is a lot of water is going in each dialysis, 150 liters per dialysis. So water resource is consumed during dialysis. And after all these centers, also how many patients we are dialyzing? You yourself pointed out, we have 2 lakh people of end-stage kidney disease every year in our country. No other country has these huge numbers. And how many are we dialyzing with all these centers? Only 50% of them. What's happening to remaining? Are they going for transplant? 1 lakh, are they going for transplant? I told you, transplants we are doing only for 15,000. So what's happening to remaining 85,000 just dying? So I think prevention is important. And as I said, for women, for men, use the dialysis centers as prevention centers as well. Educate the female attendants who come with the men for dialysis, screen them as well, screen the family. You teach one woman, you take care of the entire family. So that's what my feeling about this subject is. Thank you.
Thank you so much, Dr. Sahai. Very important aspect. And I think women are kind of sharing or having the double burden of kidney disease. One is that they may themselves suffering from the problem just because of their, higher predisposition to even NCDs like diabetes and hypertension and all, even obesity, which is a big issue, as you highlighted. And at the same time, they are not getting enough attention to their health. They are, as you mentioned, that only 20 to 30% are women which are getting dialysis. 70% of the other people who are getting dialysis are men. That while the burden is being shared almost equally by both the genders. Urvashi ji, along with your many areas of focus and passionate advocacy and policy work, women health is also one major area where you have been very passionately working on. And as we highlighted about NCD burden, where we have seen that a higher number of women are having NCD, if we see, which is almost double than the men. And the same is kind of contributing to higher burden of kidney diseases as well. How do we address this problem? Is the time of prenatal care can also be a good opportunity? Is the workforce at that level trained, as Amitabh ji said, that they have worked towards training and capacity building of kind of general physicians? Have we done the same for gynecologists also? Do we need to do that? How do you see, addressing this gender disparity for disease like this, which is really, adding to a lot of morbidity, sufferings, and even deaths?
Yeah, I mean, I think as Dr. Sahai very rightly pointed out, the gender dimension to this. And so I think there's one, broader societal dimension to it, which we have to tackle, which is that, yes, women in general, if you see, this is true for kidney disease, but it's as true for many other health conditions that, women tend to neglect, their own health. They tend to come to the health system only when things have reached a very advanced stage, things like preventive screening or, early detection. I think we are much further behind when it comes to women, because a lot of it is also our socio-cultural dimensions and the way women themselves are, this aspect of altruism that she spoke about. While there's positive dimensions to it, there's also on the extreme end of it some amount of self-neglect, and putting your priority, your health on the back burner. So that is, of course, one dimension that I think it's not just government but all stakeholders, including civil society here, plays a very, very important role in trying to change that whole behavior almost that we see among women. And of course, if we have to change it, it's not just addressing the women, but we have to also include their families. We have to address the men who are around them and encourage them that please encourage women in your household to come to the health system at an earlier stage, to get screened, to be more proactive, rather than waiting for something advanced, to actually happen. So I think that's one dimension. But the other dimension is very much related to our health system. And, like we've been speaking, that whether it's the gynecologists, whether it's other health workers, whoever interfaces, with women, wherever you have these touch points between the health system and a woman, and it might be for any health issue, it might be for pregnancy, it might be for some other health, completely unrelated health issue. It's important to try and use those touch points to also create awareness about this, to also bring women forward for screening and early detection. So I think that is also a very important point, the point of co-location also that Dr. Sahai was making, that you have a dialysis center, you almost kind of co-locate a screening center, early detection center with that, and you kind of, the women who are anyway coming there, you try and draw them there and say, you also get screened, or you also get yourself checked. So I think those are all very important strategies as well, that we need to do to some extent. We have started working on a lot of these aspects with various state governments. Also, we are trying to address these aspects. The transplant aspect, as again she mentioned, we are even trying to see if we can get that into the curriculum, that why this is something which is so important, this is something we need, and equally we need to address the gender disparity there too, this whole male female disparity that we have even when it comes to transplantations. So I think that is one piece of our action, but I think one cannot underestimate the broader societal effort that we have to put in here to make sure that women stop putting their own health on the back burner. They themselves are have more agency to be able to come forward, to get screened, to go through early detection. So I think that is something that definitely needs a broader and intensified societal effort with all stakeholders. Government undoubtedly has a very important role to play, but I think all stakeholders have a very key role here to play to change this sort of socio-cultural barrier that we're actually dealing with in healthcare.
Wonderful. Thank you so much, Urvashi ji, and very important. I am sure that you will be also kind of looking at when the policy making processes are happening, that how we can address these strategies. Amitabh ji, since you mentioned about skill capacity building of physicians, and a good work done by Dr. Reddy's and ISN in that area, how do you see that, as Dr. Sahai also highlighted, pregnancy is becoming a big contributor in terms of kidney disease among women. Do you see that the similar kind of effort need to be channelized or put in for sensitizing, can be skilling gynecologists and their kind of affiliate workforce, nurses at maternity centers or paramedics and all those, to kind of look into these aspects as well?
Yeah, Kamal, thank you for asking this very nice question. First of all, it's a new learning for us that we were talking about physicians who were treating diabetes and hypertension, etc., where we were focusing in the last few years. Now, this is a new learning that gynecologist and the segment of importance of women being not getting into the right kind of treatment and negligence that is happening, as I learned from Madam. So it's definitely another area for us to work on it. And definitely we will try to work out something which can help to bring awareness for the females, and get them into the priority, not only at the gynecologist level, but also at a social level, how we can help it. Let us work it out. Definitely gynecologists intervention, because they trust them a lot. As I understand, the females trust the gynecologist a lot, because they are there with them for at least a good number of couple of years in their life minimum, over the period of time. So they trust them a lot. So that's an opportunity to gain confidence and work out with the gynecologist with the help of ISN again, how we can bridge this thing, and we will certainly work on it.
Thank you so much. A quick question, Urvashi ji. We are kind of reaching to the end of this session, but in IHW Council, we have been trying to kind of bring together multiple stakeholders and people and also looking at health on a holistic point of view. We are very clear, kind of, it has become very clear by from what experts are saying, what you highlighted, and what numbers also say, that diabetes, hypertension is contributing a lot when it comes to kidney diseases. Then also pregnancy related issues, then as well, a lot of environmental factors which Dr. Sahai talked about. While we see that general physicians being involved, and you also highlighted that non-specialized cadres should be more focused on, should be trained, and capacity building should be done for them to kind of pick up these signs and symptoms. How do you see, do we have any mechanism within the policy framework also, or in the process of policy making, where we engage all these stakeholders? So from diabetologists who are supposed to look into diabetology and diabetes, but at the same time they also have the responsibility to look at that if it is not a kind of progressing to anything of this sort like kidney disease, from general physicians who need to be very careful that they look at who is getting into the border of borderline diabetes, or how to prevent that, to gynecologists, having a cross or multi-specialty approach when it comes to addressing these diseases, which are kind of having the etiology of one or the other disease. Do we have the similar kind of framework when it comes to policy creation, or there is a need of doing that?
Yeah, I think, so again, there's I think two dimensions to it. One, looking at things from a public health point of view, and that will incorporate what you're talking about as looking at health very holistically, and that is what I was speaking from the outset, that this shift from looking at just one speciality versus another, to say that let's look at health in a very integrated manner, and a public health approach on its own will actually compel you to do that. And so a lot of our efforts are on the public health side of things, even when we engage with state governments, to say that of course you have your medical side, you need to increase your specialists, you need to do all that, but also bring in this public health holistic approach, where you look at the entire individual as one entity, mind and body, and ultimately everything is connected. You can't say I have a heart patient, so I don't need to bother about his or her kidneys, right? Or I have a cancer patient, so I probably need to think about his or her cardiac issues also. That is the nature of how the human body is. So a public health approach is very, very important in trying to break down these silos and barriers. So I think that is one push we are giving from the policy side. But the other, as I did say, that starting from the very curriculum, which is the fundamental, and curriculum is not your one time what you study, but even your refresher training, your continuous medical education that we have, the modules that a panelist was talking about. We are also trying to build in fact, digitally now we have the opportunity to impart a lot of these modules digitally. COVID has kind of taught us to do that. So we are also trying to use those channels to build in these interlinkages, between specialities, and make sure that, yes, while somebody might be super specialized in one area, we don't neglect the other issues, that are related to that. So I think we are working on both those kind of parallel fronts, and we need them to run together. We need our specializations to run together with our holistic public health, approach. That's the only way that, we'll be able to kind of address this. And there shouldn't be like one versus the other. These two really must go hand in hand.
Thank you so much, Urvashi ji. Very important that we need to bring in a holistic, integrated and public health approach when it comes to dealing with the health of the humans, and also the health of the environment, everything interconnected. It has been a very insightful discussion this morning on the first and the inaugural session of Kidney Health Summit. I thank all our speakers who took out time from their busy schedule. Dr. Bhalla was traveling on some urgent assignment. Still, he connected, and also keeping in mind that it's a Saturday morning. Thank you so much, all our speakers. I'm sure the lineup ahead today in the Kidney Health Summit, we already see 3 experts on the screen, as we are going to hear a lot of important insights, and also which is going to help us chart out and highlight the strategies which we as a civil society institution, the government, the policy institutions like Niti Aayog, or the pharmaceutical and healthcare providers like Apollo and Dr. Reddy's and many others, all need to work and ISN and need to put their efforts together so that we are able to address these growing challenges of various NCDs, and very specifically about the kidney disease as well. So the next panel is going to be moderated by Dr. Karan Thakur, the group lead and of sustainability and ESG and vice president for public affairs at Apollo Hospitals Group, along with a very accomplished set of speakers in this next session. Over to you, Dr. Thakur.
Thank you, Kamalji. Thank you for that wonderful session. It was quite an eye-opener, and you conducted it, as always, with great elan. I'll move on to this next session. And as you rightly said, this is an exciting session because after all the deliberations that we heard in our previous, the panelists speak about the entire gamut of issues and also touch upon policy around kidney disease. It's now time to actually deep dive into a better and deeper understanding of chronic kidney disease, its burden, its stages, and what can patients do, and also how should the landscape around the entire disease that is prevalent, how do we evolve the landscape through policy and through other interventions to ensure that every person who needs and desires any intervention on kidney issues can get those. So I'm delighted to be joined by this expert panel. Professor Manisha Sahai, the HOD Nephrology, Osmania General Hospital and Osmania Medical College, Hyderabad, is with us. Thank you, Professor Sahai, for being here. Dr. Kamlesh Parekh, Senior Transplant Physician and Consultant Nephrology, Srinath Clinic, Baroda. Thank you, Dr. Parekh, for being here today. Dr. Sampath Kumar, Senior Consultant in HOD Nephrology, Meenakshi Mission Hospital and Research Center. Thank you so much, Dr. Sampath. Dr. Tarun Kumar Saha, who I think will be just joining us shortly, Senior Consultant Nephrologist and Transplant Physician at Yashoda Hospital, Sikandrabad. Last but not the least, Dr. Shashi Kumar, Consultant Nephrology, Paras HMRI Hospital, Patna. Thank you so much for this entire panel for being here with us today. Professor Sahai, you touched upon this in your previous panel, but for the benefit of those who are just joining us, could you please throw some light on kidney disease, the burden and the prevalence of kidney disease in India as a whole?
So thank you for that question, and good morning to everyone who have just joined in. So as I said already, and I keep on repeating this because people should understand it better. The more it is said and highlighted, the better. So diabetes, I keep on asking my postgraduates as well. So prevalence of diabetes in India, 20%, 18 to 20%. And hypertension is around 25%. Kidney disease, no answer. That from our postgraduates. From general public, the situation is even worse. So people think kidney disease does not exist. The questions we get are, where are the kidneys? What are the kidneys? Nobody knows about the kidneys till they fail. So to put a long story short, what then is the prevalence of kidney disease? So as per one of the studies, the SICK study, it said it's around 17%. So there are different opinions, but roughly take it around 15 to 17%. And it's not far behind diabetes. So we need know everything about diabetes. Each patient knows about diabetes. Each patient knows about hypertension. In fact, not patient, even the general person, lay person knows about diabetes and hypertension, but awareness of kidney disease is very poor. Kidney disease affects 1 in 8 Indians. So out of the panel here, I'm sure one might be having kidney disease. Are we aware of it? No. So it's that prevalent. Now, you asked also what are the major causes of the kidney disease. The major cause still in India as of now is diabetes. Another important cause is hypertension. The third important cause I would like to say is CKD of unknown etiology. Nobody knows. We have a lot of young individuals in India who are developing kidney disease. They don't have diabetes. They don't have hypertension. So that's also quite worrisome. Nobody knows exactly what's the cause. A lot of research is going on. It's been reported in different parts of India. And the presumptions are that it is either related to the environment because of heat stress, maybe because of some indigenous medicines, maybe some say it's because of toxins in water, some say it's because of repeated episodes of dehydration, global warming. So a plethora of causes, which truly says that we do not know exactly what the cause is. So that's the third important entity. Next important entity, which all Indians should be worried about, is obesity-related kidney diseases. Obesity is a lifestyle disease, and diabetes and hypertension, they go hand in hand with obesity. And 30% of our population has become obese. Till few years back, we were talking about undernutrition. Now we have to talk about over or maybe abnormal nutrition. So we are taking nutrition, we are taking lots and lots of calories, but what we are taking is wrong. We have moved from the Indian food to the Western diet, which is not working for us. Along with an unhealthy lifestyle, sedentary lifestyle, we are all in front of computer screens. We are using our brains more rather than our hands and feet. Physical activity has drastically come down. So 45 minutes per day, simple walking is supposed to be enough. We are not doing that. So that's the fourth major cause. The lifestyle change has become the major cause of CKD in our country. Apart from that, we should not forget the stones. India comes in the stone belt because of its high climate and less water intake. So minimum, we should drink around 8 glasses of water per day. I'm sure many of us don't. We forget it. We are now putting alarms for drinking water. We preach others, forget to take it ourselves. So stones are another important cause. Apart from this, the ever-prevalent infections, we can never forget in India. And in the last panel, we were also discussing about long COVID, so on and so forth. So right from the basic old-time infections, malaria, dengue, leptospira, they are not over yet. So many infections. And now we have plethora of new infections added to this as well. So infections are definitely there, inadequate treatment of infections. And then again, we did discuss about pregnancy-related kidney diseases in India, which have almost disappeared in the Western world, but we still see a barrage of them. They present with acute kidney failure, and if not managed properly, many of them go into chronic kidney disease as well. So these are the major causes. You have plethora of other causes as well, the less common causes, the diseases inside the kidney, the glomerular diseases, the tubular diseases, interstitial diseases, the obstructions, cancer cervix, that's one important cause, obstructive uropathy. Cancer cervix, we see so many patients, it's so scary. Many of our younger females are not vaccinated with the vaccine. A simple vaccine could prevent, go a long way towards prevention. And in males, again, we see prostate-related problems. So these are some of the causes of kidney diseases in India. In addition, we have drugs, painkillers, over-the-counter use of drugs. It's easily available in India. Besides, we have other important causes, for example, the snake envenomation, so on and so forth, the bee sting, viper bug. So all those things are there. So in India is a huge country, so many cultures, so many religions, and an equally big number of causes of kidney failure as well.
Right. Thank you for sketching that elaborate picture of the various causes, some India specific, some sort of, because of our economic growth and change in lifestyles, and some which are beyond our control, at least to some extent relating to the environmental factors and climate change, although some would argue that that's very much within our control. But you also touched upon a comparative with global figures. So Professor, how does the Indian chronic kidney disease square up with the international figures? Is it pretty much in line? Is India on a higher pedestal? How would you draw those two contexts?
So as I said, roughly all over the world, it's said to be about the guidelines, the figures issued by World Kidney Day campaign is roughly 1 in 10. So over the world. In India also, it pretty much remains the same. But again, having said that, there are different studies from India. Some of them have highlighted a much lower prevalence. This may be because of inadequate screening strategies in India. Some some countries do a universal screening, universal urine examination for all, even the school children. We do not have a universal screening policy for kidney disease in India. We screen the high-risk groups. Now, high-risk groups in India are diabetes, hypertensives, those with cardiovascular, heart diseases, those who are on long-term painkillers, those who have a family history of kidney disease, those who have had kidney disease in the past and have recovered, those who are stone patients, those who are obese, those who are elderly. So these are some of the common high-risk groups where we do screening in India. In fact, we are supposed to do screening. We do not screen many of them. And apart from that, another important coming up factor in India is HIV-related kidney disease. Now we have a huge segment of population, people living with HIV. Because HIV is not a killer anymore, people are surviving and thriving on HIV medicines, and many of them have kidney disease. So these are the risk groups identified by the International Society of Nephrology as well. For those countries who are LMIC, low middle income countries, or middle income countries where we cannot afford to screen the entire population. Some countries, they do screening, universal screening. In India, 1.3 billion screening is maybe a dream for the future. As of now, let us focus on the high-risk groups. And with the screening of these people, which is adequate, the prevalence roughly in the studies have been around 17%. As I said, 6 studies. Other studies have reported a lower prevalence. In the world also, there are certain pockets you have a high incidence of kidney disease, especially that CKDU, the CKD of unknown etiology. You have such pockets in Lanka, for example, Sri Lanka. You have such a pocket in US also, in the area around Brazil. Then you have pockets in the Middle East as well. So there are many pockets across the world where you have a relatively higher incidence of kidney diseases. And in some parts of the world, for example, in Finland, you have a little bit more incidence of genetic kidney diseases. But as I said, overall, the rule of the thumb or a common ballpark figure is 1 in 10 of the entire population of the world, and in India as well. The causes may vary across the globe.
Right, so it's a global issue of concern, but for India, given wide disparity and diversity, it becomes an issue of even greater concern. And given just the sheer size of our population, a 17%, even a percentage higher or lower than that, is a huge number, which would be equivalent to populations of many countries as a whole. And you very rightly also brought out the issue of screening and the challenges there, but how to look at high-risk groups when we are assessing and also targeting the resources that we have available with us as a health system, as a country, to be directed towards chronic kidney disease diagnosis to assess its burden. Dr. Parekh, I'd like to come to you now and ask you, basically building on what Professor Sahai mentioned about chronic kidney disease in India and some of its prevalence. But when we speak about disease burden on its own, while the statistics may suggest that it's pretty much the same in line with global trends, but we are a diabetic capital of the world. We are competing with China very aggressively, unfortunately, on that. Similarly, hypertension, heart disease is also on the rise. So in your practice, in your experience, what is the disease burden now looking like? Is it a lot of people who are coming with diabetes who also have this? Or is it people who are actually well aware of it and want to be screened for kidney disease specifically? Could you just unpack that for us? Dr. Parekh? You're on mute, Dr. Parekh. If you could just unmute yourself, Dr. Parekh. We can't hear you. Could you just up the mic, please? Okay, I think you might need to rejoin because we can see you as unmuted, but we still can't hear you. Okay, so while you do that, let me move to Dr. Sampath. Dr. Sampath Kumar, the same question that I asked Dr. Parekh, if you could just draw out some instances or your experiences on the disease burden that we see. We are the diabetic capital. We are also the hypertensive capital in many ways. How does it play out in your practice and in your experience?
Good morning. See, when I started my practice 30 years ago, I thought that kidney disease is a rare, uncommon disease, and I'm going to have a very restricted practice. Then as my practice grew and also the awareness about the kidney disease has spread, I could see that every alternate patient seems to have some form of a renal disease. So it is not only a real increase in the number of patients with chronic kidney disease, the awareness has also improved so that the burden of chronic kidney disease has increased tremendously. We used to have hardly a few, one or two dialysis centers interspersed across cities. But now we see that even a small city or even sometimes a village boasts of a dialysis center. So that tells you not only the incidence and the prevalence has increased, the awareness also has increased. Earlier, it used to be thought that it was a patient who has got a hypertension and also anemia. So they used to treat only for these by giving them iron tablets and also antihypertensive drugs. Now we are able to connect the dots and find that it is due to chronic kidney disease that these patients have both hypertension and anemia. So a lot of awareness has come into the physicians, and as Dr. Manisha was saying, that even amongst the gynecologists, the awareness has increased, and in fact, pregnancy, I would say, is one of the kidney function tests, physiological kidney function test, where the very nicely functioning kidneys, healthy kidneys pass the test with 100% marks, whereas kidneys which are bound to fail show up during the pregnancy. So a lot of these things are now picked up by not only the nephrologists, by all the other specialties. For example, I get referrals not only from the physicians, I get referrals from even dermatologists. For people who come with a lot of pruritus or scratchy skin, then they are able to make a diagnosis of chronic kidney disease. In the same way, people who visit the orthopedicians with bone pain, and they are able to now, they are aware of the kidney disease and they check the creatinine and they refer. So this awareness has got really increased the burden of chronic kidney disease in the population.
So what I'm hearing is that, because of better infrastructure, awareness, interventions, programs, we are now catching this disease. Yes. But, there's always been this debate. Has the numbers really gone up? Has the prevalence gone up? Or has better diagnostic tools and screening skewed the picture to make it seem as if cases have gone up, but they may be remaining the same? I mean, it's a debatable question, but I'd like to hear what you have to say.
I think it's a debatable question. But on the whole, I think it augurs well for the people with early chronic kidney disease, because you're able to catch them early and then you start the interventions early so that they are not going to go downhill very quickly. So that is the whole point of our discussion.
Right. I think I have Dr. Parekh back. Dr. Parekh, I'd also like to pose that question to you on the disease burden, and what has your experience been like in your practice, say for the past couple of decades, in terms of the awareness and therefore some extrapolation on the burden of chronic kidney disease.
Am I audible now?
Yes, you are, Dr. Parekh.
Yeah. So the burden is based on the kind of prevalence that Dr. Manisha has mentioned, 17% prevalence. So obviously when the prevalence is this high, the burden also will be very heavy. Now the point is, the pattern of practice in India is that there is always a late referral. So when a nephrologist see a patient, by and large, you have a patient who is coming to you with an established kidney disease. One, two, not only established kidney disease, but also in a later stage also. So extrapolating what is the disease burden in India from a nephrologist perspective is going to be not a very realistic figure, because you see an established disease anyway. So I think the need of an hour is to do a universal screening. And when somebody tells that he is recently detected to be a diabetic, it is not necessary that the diabetes is recently detected. He might be having diabetes and hypertension since very long. So actual disease burden, when I look at the number of patients, I think in our region, when we, because we have done a couple of screening camps, we have, like we went to a factory where about say 12,000 employees are there, and we screened them. So we found out that they were not aware of diabetes and hypertension. Out of 12,000, about 135 people were not aware of that they have diabetes and hypertension. And even double the number of them were having diabetes and hypertension, but they were not aware of that they need to screen for microalbuminuria, they need to screen for control of. So one tablet prescribed maybe 2 years back was going on and on without much monitoring and all. So assessing disease burden, I think it's a tip of iceberg what you are seeing in your day-to-day practice. The burden will be very heavy. The only kind of difference is that whether you are screening an urban population or you are screening a rural population. If you are screening rural, maybe diabetes prevalence is slightly less. Hypertension prevalence is slightly about 10% difference between urban and rural, 40% vis-a-vis 30%. So this disease burden, if we look at a population of India, and if you have to extrapolate 10%, you know the burden is mind-boggling figure of 17 CR. Population of India is at a risk and they have a disease.
Dr. Parekh, you mentioned hypertension, and what we are also seeing is a downward increasing prevalence of hypertension amongst the young. Although it may be too early to say, but what does research suggest that when a young person, say in their 20s or 30s, develops hypertension, does it have an exacerbated effect or impact on the development of kidney disease? Could you just highlight that?
It has an impact, and the degree matters. So the worse the control, the greater will be the involvement of kidney also. So and the longer it remains undetected, more are the chances that it may produce whatever target organ damage it has to produce. So the cardiac disease burden and kidney disease burden goes with the duration, with the degree, and with the kind of interventions, whether it is done well in time or not. Because when we see like all the current guidelines mention use of ARB and calcium channel blockers, but they might be prescribed something like atenolol or some very so the kind of practice prevalence, if you look at practitioners from the rural background or the older prescriptions, if you look at, they might be prescribed some gentle beta blocker or a diuretic only. So it is difficult to judge whether the impact of hypertension or inadequately treated blood pressure and inadequately treated diabetes, how bad it is. But most of the time you see patients with inadequate treatment.
Right. That is a bigger problem. Dr. Sampath, would you like to throw some light on this aspect as the disease now comes into a younger population? How do you foresee the burden of chronic kidney disease being impacted?
I feel the younger generation may have a different kettle of diseases, and these are the younger generation people who require real nephrology care, because you would find that among the younger generation you have diseases like IgA nephropathy and other glomerular diseases, which could be amenable for intensified therapy, which could be different from giving them merely antihypertensive drugs. So this is where very exact diagnosis is very important. Younger hypertensives may have to undergo specific diagnostic tests like urinary protein estimation and sometimes kidney biopsy to find out what exactly is the problem. And these diseases are amenable for different types of therapies, like immunosuppressive therapies, like steroids, etc. And so younger generations have to be under intensified testing. It is not merely you make a diagnosis of renal disease and give them drugs and send them away to come back after 3 months. These people require intensified tests.
Right.
Yeah.
I'll just move on to Dr. Tarun, but just before I do that, I just wanted to close this particular thread by asking Professor Sahai. So you heard Dr. Parekh and Dr. Sampath speak about the disease burden, the impact of young hypertensives on kidney disease. If you could just sort of marry that with gender, I mean, what about women with heart disease at a young age? How do you think, or with diabetes, how do you think that will impact the burden of chronic kidney disease in the future?
Okay, so now we have a study going on in India. That's a prospective study, Indian CKD study. It's a cohort of 5,000 patients across India. Multiple centers are involved, and I'm specifically looking at the kidney diseases in women as compared to men and their progression. So what we realized was that the prevalence in men and women seems to be almost equal. The rate of the diseases are different though. In a younger woman, we have SLE as an important disease, that is lupus erythematosus. So that's there in women. And over the period of time, both men and women tend to have diabetes and hypertension as the major causes in the older age groups. Carcinoma cervix is an important cause, as I already pointed out, in women, and we are not doing much about that. We do talk about diabetes and hypertension. Even that care is inadequate, but there are other diseases, for example, cervical carcinoma, which is an important cause in that cohort as well. Regarding the rate of progression of kidney disease, again, it's almost similar in the data collected till date. Cardiovascular deaths are more common in men. But here the confounder is that many of the women are lost to follow-up. They don't come, they simply don't come, they don't get the tests done on time. So that's a big problem. Equal number of men and women go to end-stage kidney disease, but once the dialysis is started, as I said, in dialysis centers, we see around 70 to 75% males, whereas women just make up of around 20 to 25%. So that's the gender difference. And then pregnancy, especially in those women who already have a baseline. So we see two types of scenarios. One is a healthy woman with no kidney disease undergoes a pregnancy, as I was highlighting, an unmonitored pregnancy. And if she develops hypertension in pregnancy and it's not adequately taken care of, some infection, they'll end up with permanent kidney failure. So this is one scenario. The other scenario, what we get is women who already have some sort of baseline mild kidney disease and they become pregnant, again unmonitored, without seeking any advice, without any follow-up either by the gynec or the nephro. And the kidney disease, which was so as to say mild before pregnancy, it flares up and then they go into permanent kidney failure. And as Dr. Sampath wonderfully put it, pregnancy is a test of the kidney function, a physiological test. So those women who undergo a successful pregnancy, at least their kidney disease, even if it's there, it's not severe. Many of the women, if the kidney disease is severe, they lose the pregnancy. Either they don't become pregnant at all. That's one of the major causes of infertility. And even if they get pregnant, they do not carry the pregnancy to term. So men and women, again, as we were discussing, they face the same challenges. Women face added challenge because of the social challenge, because many of them are homemakers, they are not breadwinners, and that probably they are not taken care of adequately. Even the screening is inadequate in them. Even in our cohort, we have less number of women as compared to men. Our cohorts are all hospital-based cohorts in major centers across country, and the story remains the same everywhere, whether it's a government center, whether it's a private center. So the number of women coming to a nephrologist is itself less. The use of painkillers is much more in women. NSAIDs is much more in women. Many of the women are obese as compared to men. they have high cholesterols. So till menopause, they are somehow protected. The estrogen protects them. But post-menopause, again, the cardiovascular diseases become quite common in women. Their lipid profiles are bad. And again, heart diseases and all. Post-menopausal, you don't see the protective effect anymore. And they also succumb to cardiovascular diseases. So I think that's quite important that again, these things also have to be looked at. And fortunately, good thing in that CKD cohort, unlike the other worldwide cohorts, is women have very less prevalence of smoking addictions as compared to men. So thankfully, at least we are far behind the West in that area.
Right. So there's a social dimension, economic dimension, and very context-specific dimension given our culture and society. So that was important to draw out there. Dr. Saha, I'd like to now draw you into the conversation. We have spoken about CKD disease burden, its rate of progression, its prevalence, the differences between the Indian context, the sub-regional contexts, and the global context. Also, we've spoken about and covered a lot of ground, in fact, on what are the risk factors and also why we are seeing an increase in burden, but some bright spots also in terms of greater awareness that is now driving people to get attention at the early time, as early as possible, but again, challenges there. But we are doing this all under the assumption as if everybody understands what does kidney disease look like. I'd like you to inform to our viewers and the audience here about what does kidney disease actually look like? What are the signs and symptoms? And how does, we spoke about early diagnosis, but how does one go about diagnosing chronic kidney disease?
That's a very interesting and good question, because we all talk about the early diagnosis. How do you make the early diagnosis? Dr. Manisha was mentioning about the screening, but technically many times it is not feasible for several reasons. And let us understand that how the kidney diseases are different from the heart disease or gastrointestinal disease or neurological disease. You see, if you have a chest pain, you do not need to tell every patient will go to straight away to cardiologist without even going to internist. If you have a persistent cough, they will probably go to pulmonologist. If you have a stomach pain, they will go to gastroenterologist. If somebody has a fits or headache, we will go to neurologist. But for what symptom, people will consult nephrologist. There is lack of organ-specific symptoms for kidney disease. The symptoms of kidney disease may be swelling of feet, high blood pressure. These are the two early symptoms, but for these symptoms, patients generally go to other specialists. Like they may think, first of all, many people think that swelling of feet after a prolonged stay, sitting or walking is a normal phenomena, or they can go to a thyroid specialist. Somebody makes a diagnosis of hypothyroidism by little elevated TSH, which is common in CKD patients, and miss the diagnosis of CKD unless you do serum creatinine estimation. So lack of organ-specific symptoms makes the delay of early diagnosis of CKD, making the only option available is to do a screening or regular health checkup in the form of urinary protein estimation and estimation of serum creatinine. Another interesting thing is that one of the earliest symptoms of CKD can be nocturia. That means normal individual, the daytime versus nighttime urine volume ratio is 2:1. When we sleep, the nature decides to decrease the urine formation, because sleep induces the activation of antidiuretic hormone and tubule responds to it and suppresses the urine formation. In chronic kidney disease, there is tubular insensitivity towards the antidiuretic hormone, which normally gets stimulated with sleep. This insensitivity of the tubule makes the patient to pass same amount of urinary volume, what normal people will suppress it. So there is increased production of urine during the night, which makes the patient to pass more urine in the night. Again, some people may think that this is normal, or some people, particularly male, may think that this is due to the aging and prostatic hypertrophy. So many times the early warning symptoms are missed not only by the patient, but also by the treating doctors. So we need to keep these subtle symptoms and signs and screening. These are the two modalities for making the diagnosis early so that we can institute the therapy and decrease the progression of kidney disease.
Right. So you spoke about the modalities that are available for diagnosis. If a patient were to come to you with, say, swelling in their feet or hypertension, and hopefully they come in time and come to you, what are some of the workup modalities that are done for you to ascertain that this person may have kidney disease or chronic kidney disease?
Yeah, just as I said, that for early diagnosis, you need urinary routine examination, which will tell us about protein.
We seem to have lost Dr. Saha. I'll wait.
Depending.
Yeah, sorry. Yeah, could you just restate that? We just lost your audio in between. Yeah.
Right. So estimation of urine for protein, microscopic examination of urine with RBCs, pus cells, and many other features in the urine, routine examination, and estimation of blood creatinine, electrolyte, bicarbonate, calcium, phosphorus. And depending on the case, we are suspecting a systemic disease like lupus and many other diseases. Depending on the suspicion, we investigate them for immunological workup or immunological diseases which can cause kidney disease. And as we have discussed, that diabetes is the commonest cause of chronic kidney disease across the age and over total populations of CKD if you consider. But there are many congenital causes of CKD. There are drug-induced causes. Some people may be taking on some indigenous medicine which can cause CKD. So the list is very long.
Right. And what about genetics? If somebody has had a family member who has had chronic kidney disease, and probably, there would be a history of diabetes or hypertension, but otherwise, specifically for CKD, does it have a genetic connotation also attached to it? I've lost Dr. Saha. Dr. Shashi, let me ask you that question. We spoke about, the workup to be done. Dr. Saha, are you back with us?
Yes.
Yeah, sorry, we lost you. Your screen froze. Dr. Shashi, I'm just coming back to you, but I just wanted to throw that question to you around genetics and whether that plays a role in chronic kidney disease.
For me?
Yes.
Yeah, so genetic is important in most of the kidney diseases, directly or indirectly, high prevalence, high probability or less probability. Even in diabetic nephropathy, you have a genetic predisposition. And the genetic diseases which causes kidney disease are polycystic kidney disease, Alport syndrome, and the list is long, sometimes FSGS. So there are long list of genetic diseases which not so common, uncommon, but even I must emphasize that diabetic nephropathy also has a genetic predisposition.
Right. Dr. Shashi, I'd just like to bring you into this discussion now. We've spoken about prevalence, we've spoken about rate of progression, about burden, about Indian specific context, and Dr. Saha just highlighted how you can diagnose, what are the symptoms to look at, both from the patient perspective and also from the physician's perspective. Now, I'd like to move this logically towards treatments. CKD, as we know, requires interventions, whether it is pharmaceutical or other interventions. Could you please elaborate on what treatments are usually available and what routes are taken when intervening for CKD?
Yeah, so good afternoon to all. So currently this is a very practical question. So we are discussing till now how we can screen our population, how to diagnose early. But one thing we all realize that the patients with chronic kidney disease, their health strategy is lower as compared to other patients without CKD. Why so? Because most of our patients have multiple comorbidities. Most of our patients are suffering from diabetes. Most of our patients are suffering from hypertension, dyslipidemia, elderly age, stroke, cardiovascular diseases. So health status of our patients are poorer than the other patients without CKD. Another thing I want to highlight here is the awareness of CKD is quite low. So we have paucity of data from our country, but even we look at the US data, and they have recently published their KEEP study, and they found that those patients, even CKD stage 3, only 20% of patients are aware of their disease burden. And when we look at the advanced renal failure, even in those patients who are CKD stage 4 and 5, only 50% of those persons know their disease burden. So US is a highly intellectual country, and we know that they are high literacy than are, but despite this, they have low awareness of this CKD burden and what we can say about this our country. So what we need to do is we integrate. Despite in recent years, government have increased the seats for DM training and DNB training for nephrology, but despite that, this handful of nephrologists are concentrated in cities only. Very few nephrologists you will see in the small towns or in villages. So we need to integrate our other colleagues, our physician, our rural medical practitioner. And what I want to highlight here is, if patients come to us, we'll try to give the best possible medical care. But what about those persons who cannot reach to us? Those who are living in small towns or in villages. So what we need to do, we need to develop and implement a CKD detection protocol that defines the population at risk, as Dr. Manisha Shah has already mentioned regarding this. And we need to leverage the health information system to identify and track at-risk patients. Apart from that, we need to promote detection at every opportunity. And for that, we need to integrate the CKD guidelines into the control of diabetes or hypertension or cardiovascular condition. Meaning by, we need to tell our physician colleague, we need to tell our cardiologist friends, we need to tell our endocrinologist friends, if that patients come to them, they need to do for early investigation for chronic kidney disease. And when we look at the guidelines, even the ADA guidelines or our own KDIGO guidelines, even the European Association of Study on Diabetes guidelines suggest that all patients with type 2 diabetes must be investigated for kidney disease at least annually. So if we do that, we try to pick patients in early stage. And if we pick patients in early stage, we can halt or decrease the progression of kidney disease in these patients. Now, coming back to your questions, how do we going to treat? So as I mentioned, our patients have multiple comorbidities, and kidney disease is mostly a secondary outcome out of primary disease like diabetes, as mentioned by Dr. Sahai, hypertension, painkillers, use of painkillers or pregnancy related. So we need to treat the basic disease. The primary importance is to control the diabetes, to control the blood pressure. Apart from that, we need to take on dietary modifications. So that is again a very important point, which we usually forget to tell our patients because of busy practice, because that needs again your 5 to 10 minutes for each patient. So either we need to keep a dedicated renal nutritionist in our hospital or in our clinic, so that they can talk about the diet. And we have few treatments, I must say, in recent years. We have few medications like SGLT2 inhibitors, like GLP-1 receptor agonist, like non-steroidal mineralocorticoid receptor agonist, which can decrease the progression of kidney disease. So we need to give this medication to all the eligible patients to halt or decrease the progression of kidney disease. And I just want to highlight this creatinine is not just a number. So many a times your physician friends at your smaller towns, they think that what a nephrologist do, your creatinine is not much. But I must say that we tend to do much more than what a creatinine tells us. We need to take care of their anemia status. We need to take care of their CKD MBT status, and we need to take care we need to take the holistic approach regarding the treatment of kidney disease. So treatment is mainly based upon the basic disease, control of basic disease. Complication arises out of chronic kidney disease, their nutrition, and all those parameters.
Right. Could you also throw some light on the advancements in treatments that have happened? I mean, one hears about the vast expansion and reach now of modalities like kidney transplantation. We have talked about, advancements in dialysis, one hears about, and also things like robotics. I mean, how do you see all of this impacting how we respond to the disease burden of CKD in India?
Yeah. So definitely that is the unfortunate scene, and we all must be appreciating these things, is that we have very few options for our patients. So going back to 60s or 70s, when hypertension was first identified as a risk factor for chronic kidney disease, and in 90s and early 200 we have ACTBTs or ARBs, which shown some delay in progression of kidney disease. And with a span of 2 decades, we have nothing else to decrease the progression of kidney disease. But now we have some classes of drugs like SGLT inhibitors, we have GLP-1 receptor agonists, we have finerenone. So by this, we can decrease the progression. But despite doing best, there are still the residual risk which can progress your kidney disease. And a stage will come where the patients need some kind of renal support in the form of dialysis or transplantation. So we have definitely progresses much more in our techniques of dialysis. We can do high flux dialyzer use. We can do hemodiafiltration. We can basically, by doing hemodiafiltration, we increasing the solid tolerance, because many a times your large middle molecules cannot be excreted with your normal dialyzer. But while using this hemodiafiltration, we increase the solid tolerance from the patients, and that tend to increase the quality of life as well as longevity of life of the patient. Even in the transplant, few years back, we are very handful of centers are doing renal transplants, but now we have multiple centers across India. Even in small towns have transplant centers, and we are performing renal transplant at the centers. Robotics has again, it's handy to our surgeons to perform the transplantation in a better way. So these are the technical advancements in the management of dialysis and renal transplantations.
Right. Dr. Saha, I just want to bring you in terms of staging. We know that CKD has many stages. Could you just briefly tell us about the various stages, and how does treatment get changed, oriented, or modified basis the staging?
Well, staging is proposed few decades back when we changed from the name of the disease from CRF, chronic renal failure, to CKD, and thereby stage 1 means any kidney disease with a normal GFR, and then comes stage 2, stage 3A, stage 3B, 4, and 5, depending on the GFR above 60, in between 45 to 60, 30 to 45, they are called stage 3A and B respectively. And then you have stage 4 from 15 to 29, and below 15 is stage 5. But staging is important for few guidelines to guide you how to treatment. But overall, it's the earlier you start treatment, the better. Now, Dr. Shashi Kumar was telling that 2 decades we are waiting for some more drugs in our armamentarium, but when we got that at least two new drugs in the form of tablet, which we can use to retard the progression, particularly in diabetic CKD, although it's not so much proved to be non-diabetic CKD. So those 2 drugs like SGLT2 inhibitor or finerenone is a new addition in last few years, which definitely will help. But most of the drugs, the studies with stage 4 and stage 5 have not been studied well. Even these 2 drugs are allowed to be used up to the GFR of 30 or at the most 25. So with future studies, these 2 drugs, I think, can be utilized even below 20 GFR. In that case, we will be able to do much more justice to our patients, because most of the time, whatever you do, people come to us when they are in stage 4 or stage 5. Very less patients, they do come to us on stage 2 and stage 3. That is when the GFR is above 60 or in between 30 to 60. So the ACE inhibitor ARB is there for a long time, and because of fear of hyperkalemia, it is not so extensively used in the higher stages of CKD like stage 4 and stage 5 or even stage 3B. But the crux of the management of CKD patient, whenever you use all these three, particularly these two types of drugs like ACE ARB or the mineralocorticoid receptor blockers, you need to be careful about the potassium. So how we decrease the potassium intake in the diet or plan to remove the potassium from the body by several ways. Like one way is to prevent the constipation in CKD. In CKD, what happened? Colon starts increasing the secretion of potassium through the gut. In CKD, there is a mechanism where there is more secretion of potassium from the colon. If the person is constipated, this mechanism doesn't work. Whereas if you can produce 2 to 3 stool without producing a diarrhea, that will improve. So there are new drugs available which can be used to treat or to prevent the hyperkalemia when you are using these drugs. So I think we have an exciting future whereby we can sort of prevent the hyperkalemia, but use the ACE inhibitor ARB and mineralocorticoid receptor blockers, particularly the newer one, to prevent the progression of CKD. Having said that, the basic principle remains to control the blood pressure tightly, optimally, with optimal drugs, preventing the dehydration, avoiding the nephrotoxic drugs, regular monitoring, weight reduction, and decreasing the morbidity which are generally associated with CKD, as the previous speaker was discussing.
Right.
So these are the approach to manage the CKD patients.
Right. Thank you for that. We're drawing this very interesting conversation to a close for the rest of time. But since we have these fabulous 5 panelists here, as we close, I'd just like all of them to comment on their Panch Amrit, as it were, from the 5 that are here. When they look at kidney disease in India, its burden, its prevalence, given their vast experience, I'd like them to throw some light on 5 things that we must do to address this problem, which can have a disproportionately positive impact on the entire disease burden that India is witnessing and unfortunately is projected to increase. So coming to you first, Professor Sahai, what is your Panch Amrit for CKD?
So thank you for putting it nicely. My 5 points, first thing is, we should practice what we are preaching. Implementation is important. And how do we go about it? Simple 10 commandments. So Indian public, Indian physicians, GPs, everybody would understand 10 commandments. Whom to screen, how to screen, when to screen, and what do you do if it is positive? What medicines? That's it. Just put it in 10 commandments, and that should be widely spread in simple language. No references, nothing, but the 10 commandments, which should be there on all social media, vetted by everyone before they go out. But that is the Panch Amrit number 1. The second one is diet counseling. It doesn't suffice to tell less oil, less salt. You should tell them half liter oil per person per month, half teaspoon salt, 6 to 8 glasses of water, cut down on mutton and chicken, and move from brown to white. Write it on your prescription if you want to. So that is the second Amrita, which should be told to all the patients. The third Amrita is 45 minutes walking daily. The next one is, we are all talking about the newer drugs. The speaker talked about, we have Finrenone, we have SGLT2. Are they there in the government system? They are not. They should be made a part of essential medicine list as soon as possible. So they are available in private, public hospitals everywhere. Another important thing is the prescription audits. So whether these prescriptions, whether these guidelines are followed at each and every level. We are talking about it, but are we writing the ACE inhibitors? Are we writing the SGLT2 when indicated? Many of the prescriptions, we are not doing it. So that's the fourth point. And the last one I would say is, maybe we are talking about diet, everything. Policy should change. In schools and colleges, instead of having fast food joints, why don't you have healthy food there? So we keep on talking about it, but we should practice what we preach. So I think the whole outcome of all these excellent webinars, we will achieve our goal if we are able to implement at least a tenth of what we have discussed. So that's it from my side. Thank you.
Thank you. Thank you for that. Dr. Parekh, your Panchamrit.
I will like to tell you from the point of view of telling to the people, when it comes to most of the knowledge that we have to share with others is in English and it's not in the vernacular language. So we must put an effort to, when it comes to educating mass, you must be using the local language. That is one. Two, so where do you partner with for that? I think the social media, the newspapers, and some NGOs so we need to train a couple of volunteers. Like in Vadodara, we have something called India Renal Foundation. So they are volunteers. They go to, say, industrial organization, they go to schools, they go to some senior citizen forum, and they put all the banners in Gujarati, and they have been trained by me and others to tell that this is how you will look after your disease, this is how you will come to a nephrologist, this is what is to be done to protect you, something like that, and the importance of screening. So I think this goes a long way, that we need to take a, I mean, it cannot be that we discuss among us. It should be discussed with each and every stakeholders, including pharmaceuticals, and where they can be really contributing to us in a dynamic way to help.
Right, right. Dr. Sampath Kumar,
my only one-liner will be that at least once a year, you would definitely do a screening test to see that your kidneys are okay. So that alone will ensure you that you are able to catch it early and then take the appropriate steps. So at least once in a year. So you have it as your birthday gift on the birthday. Have a health testing rather than cutting a cake. Do a health checkup on yourself.
Right. I think that is equivalent to 5 good advice that you could give. Dr. Saha?
Yeah, before I give my, whatever slogan, what you're telling, first of all, a few things to Sampath. Sampath, you are a very roaring practitioner for probably 2.5 decades or more before when you started your practice, because you said that you were worried whether the nephrology will have a practice or not. So you are roaring. Second thing is that, in USA, when you, at your 50th birthday, you are supposed to have colonoscopy to renew your insurance, to prevent, to look at the polyps so that you do not develop colonic carcinoma. They will not renew your insurance.
I think we just lost Dr. Saha there. I'll wait for him to come back. Dr. Shashi, why don't you?
Sorry?
I'll just come back to you, Dr. Saha. We just lost you in between. Dr. Shashi was just giving his Panchamrit, and I'll come back to you for your punchline.
So the 5 Panchamrits from my side is a 5 golden rule to keep your kidneys safe. The first of them is healthy lifestyle. So keep adequate time for your yoga and exercise. The second Panchamrit is good control of blood pressure and sugar. And through ISN, we launch a campaign to just keep a chutki of namak come in your diet every day and 1 teaspoon of sugar less in your daily diet. That's suffice enough. The third advice is avoid the over-the-counter drugs, especially the painkillers and antibiotics, which you are taking without the medical prescription. Fourth is no addiction, especially stop smoking and consume alcohol at the in the prescribed range. And fifth, last but not the least, is regular checkup for your exercise, as Dr. Sampath Kumar has mentioned, at least annually, especially in the high-risk groups. So these are the 5 amrits from my side.
Thank you. Thank you so much. Dr. Saha, last word.
Yeah. So I would try to give more emphasis on hypertension. We need to have a tight control of blood pressure with optimal target. We need to look into the diurnal blood variation when we try to control the blood pressure. We need to use the proper protective drugs when you are trying to control the hypertension. We must avoid NSAID when you are taking a particular class of antihypertensives, particularly ACE inhibitor, ARB, and NSAID are co-toxins. And we must avoid low BP, which will impair the GFR and increase the kidney problem. So rather than giving the 5 tips, I will give the 5 tips to control the blood pressure, which is the most important aspect for CKD management.
That's fantastic. What a fascinating panel, fascinating discussion, in depth, covering such a wide scope, all on time and in time. I could not thank my panel enough for such an enlightening session where I have gained so much more knowledge, information, and awareness. Professor Manisha Sahai, Dr. Kamlesh Parekh, Dr. Sampath Kumar, Dr. Tarun Kumar Saha, and Dr. Shashi Kumar, thank you so much for joining us on this discussion on the kidney disease burden in India, and also giving your Panch Amrit on how to really tackle this as we mark this Kidney Health Summit. With that, we draw this session to a close. Once again, thanks to my panelists and to the audience for listening in. We will now be moving to our next session, and I'm handing over to Dr. Sawant, the Public Health Specialist at IHW Council. Dr. Sawant, over to you.
Thank you so much, Dr. Karan Thakur. That was an enlightening session. Now, let us move on to this session today. So good afternoon, everybody. I welcome you all to the Kidney Health Summit, an initiative by Integrated Health and Wellbeing Council, powered by Dr. Reddy's and with associate partner, Apollo Hospitals. I am Dr. Asawari Sawant, Public Health Specialist at IHW Council, and in this live panel discussion, we will dive deep into the topic of chronic kidney disease infrastructure, evaluating the role of innovation and new technologies. The global health burden of chronic kidney disease is rapidly increasing. Currently, 1 in 10 adults worldwide suffer from chronic kidney diseases. According to various studies, every year, more than 100,000 new patients are diagnosed with end-stage kidney disease in India alone. The cost of dialysis and transplantation consumes up a large amount of the annual healthcare budget. This has resulted in chronic kidney diseases becoming a major cause of catastrophic health expenditure. However, both the onset and progression of chronic kidney diseases can be prevented or reduced. In this session today, we are having some eminent experts who would be deliberating on the emerging role of innovations and new technologies to slow CKD progression. The session will dive deep into finding how the Indian population uses technology to engage in self-management and to reduce the burden and enhance the awareness of risk factors around this issue. To join us for this discussion, I invite these panelists, Dr. Siddhini Vishwanath, who is the HOD and consultant nephrologist at Manipal Hospital, Bangalore. Ma'am, we welcome you to the show.
Thank you.
We welcome you to the show. We also invite Dr. Sanjeev Jasuja, who is Senior Consultant Nephrologist of Apollo Hospitals, New Delhi. We invite Dr. Arpita Roy Chaudhary, who is Professor of Department of Nephrology at IPGMER SSKM Hospital, Kolkata. Ma'am, we welcome you to the show. We invite Dr. Rajshekhar Chakravarti M., who is the Consultant Nephrologist, Clinical Director and HOD of Nephrology and Transplant Services at Yashoda Hospital, Hyderabad. Welcome. We also invite Dr. Manjari Sharma, who is Professor and Head of Department of Nephrology at Guwahati Medical College and Hospital, Guwahati. We welcome you all eminent panelists to this discussion on the very prominent topic of CKD infrastructure and role of innovation and new technology. So let us get started. My first question is to Dr. Vishwanath. Sir, can you please touch upon the current management strategies that are adopted around CKD treatment in India, and also highlighting the role of technology and innovations that are existing there in kidney care? Over to you, sir.
Thank you very much. At the outset, I would like to thank IHW and Dr. Reddy's for the opportunity. Before we go to innovation, I think we need to have our basics right. So as the previous panel said, we should have definitely
good screening program don't allow the CKD to progress, or at least prevention. So prevention is definitely much better than going and treating, especially it is right with kidney. As of all of us know, doing dialysis and transplant is always expensive. So most of the innovation should go into screening people, where you can screen early kidney diseases and detect them early, where the innovations will help in preventing further kidney damage. So if you look at CKD innovations, I won't go into the details. There are a lot of newer drugs which we have, like SGLT2 inhibitor, fenrenone, which are known to prevent further progression of the disease. I will talk about technology innovations with respect to dialysis. Of course, any unit should have good water supply, pure water, so that we prevent infections. Now that we know a lot of centers, they have started dialysis units, we can have infections with the water. Water is lifeline for us. So people should not forget about keeping pure water. Make sure dialysis quality is good, so that we give good quality dialysis to the patients at the ground level. So that's where probably even innovations will help to see how best we can manage the water quality. As we all know, people are starting dialysis in small towns, small cities. There we cannot take any chance with respect to water quality. That has to be kept in mind. Apart from that, we have very new technologies. I think Kolkata is at forefront of doing hemodiafiltration, where people have had a lot of benefits with hemodiafiltration. In fact, this is a special form of dialysis where we use both convection and dialysis, which helps in removing of middle molecules, which is actually a very good innovation. In fact, many of the European countries have adopted. For some reasons, US has not taken up, maybe because Medicare has not approved it. We have had many patients who are not doing well with hemodialysis. Once we shifted to hemodiafiltration, they are doing very well. In fact, hemodiafiltration has shown people to survive longer. Cardiac benefits are there. Hospital admissions are much lesser. Mortality is better. Quality of life improves. This is something short of doing transplant. So definitely this innovation has helped us to prolong patients' life, reduce their disease burden, especially people who have cardiac risk factors, who have a lot of itching, skin lesions. Hemodiafiltration has helped. There are a lot of new filters which have come, which we are using. Of course, apart from bigger dialyzers, we have had filters called as, which are something similar to plasmapheresis, which has come from few other countries, where we use it once a week, once in month, to reduce middle molecules. It is called HA130. I'm not sure how many of you have used it. I have used it personally. It is very good membrane, which can be used once in a month to at least remove middle molecules, which helps in preventing skin lesions, skin itching. You might have seen many patients who are on good dialysis also have a lot of itching symptoms. This is probably because of a lot of molecules which we are not able to remove. These are newer dialyzers which we need to consider in these patients, apart from high flux dialysis. The third good innovation in dialysis is in CAPD, where we have automated peritoneal dialysis. We have many patients who use it at home, where you need not do manually. If you keep on doing manually, patients also will burn out and the families get burnt out. So that's the reason probably PD was going away from people taking up from dialysis. So PD can come back if we start using more and more automated peritoneal dialysis. In the form of a very small suitcase which can be used in the night, and daytime patient is free to do dialysis. Transplant innovations are separate. I'll talk about it later when the time comes. So basically, we have newer forms of dialysis, which includes hemodiafiltration, which includes newer forms of membranes, high flux dialysis, and of course, peritoneal dialysis innovations, which could be used in specific patient settings. Thank you.
Thank you so much, Dr. Vishwanath. As you pointed out, that this newer innovation of hemodiafiltration hasn't been adopted by US as of yet, because of the approvals that has not been received by Medicare.
Yes.
So my next question is to Dr. Arpita. Ma'am, what are the other such barriers that still exist in your, that you observe in your practice around renal disease support and treatments in India, such as, barriers around policy, regulatory, or implementation aspect? So what are the barriers that are limiting good care in renal support?
Thank you, Dr. Savan, for your question, and thank you, IHW Council, as well as Reddy's, for making such a platform where we can sit together and discuss, which will be further adding to advocacy to each administrator. So what I feel, I'm rather being little away from this hemodiafiltration and being what barriers actually exist. If you know that through PMNDP project, Prime Minister Dialysis Yojana, we have extended dialysis to almost all districts, the larger districts having more than 1 units available. Still, the studies reveal that there is a significant dropout in the population. So you are offering free of cost dialysis, you are offering free medicine, you are thinking that your low socioeconomic condition people will turn up to pick the advantage, but they are not coming. Where is the barrier? The barrier is the out-of-pocket expenditure. Suppose there is a district health center which is holding the dialysis unit, and the patient needs to travel 20 kilometers, and the patient does not have enough money. The person who will be accompanying the patient will be out of daily wage, which is difficult. So they are missing dialysis. We are losing patients because of volume overload. They are becoming irregular in dialysis. And another gap that we couldn't bridge up in the dialysis care is adequate number of fistula creation time ahead of dialysis initiation. So the knowledge should spread to the ground level. Sometimes we have real depth of nephrologists to check the patient at CKD 2-3 level, so that we cannot educate them properly. So this knowledge should reach the primary physicians also, at which stages these patients should be, particularly the diabetic patient should be attending the fistula creation. All these new innovations will fail if we do not prepare the board adequately. So this AVF creation, emphasis on that, may minimize the number of infections that is killing the first 3 months patients on dialysis. So these are the practical barriers which exist with a lot of our patients. Second, I'll discuss the prevention aspect later, but the prevention aspect is also should play a very strong role in LMICs like India, because you can't afford the treatment of so many patients with dialysis and transplant. So prevention aspect, innovating new technologies should be taken in support for spreading the prevention message. You can empower your community health workers with adequate smartphone guided guidance, so that they can really become a good advisor for the large population whom they have access to. Actually, in our country, we have neglected these community health workers. We did not pay them adequately. Now they are overburdened. So these are the actual practical barriers that exist in execution. We are all talking, and government probably is taking measures being influenced by what we are proposing. But what the gap is remaining between the theory and practice are probably these few.
Thank you so much, Dr. Arpita, for so explicitly highlighting the different kinds of gaps that still exist from the understanding point of view, the knowledge gaps that are there amongst patients, as well as the executional gaps that India should need to look upon, and there is a wide need to cover them. So my next question is to Dr. Raj Shekhar. Do we have Dr. Raj Shekhar Chakravarti with us? Yes, yes, sir. So, sir, all these gaps that ma'am has pointed out, do you feel that there are also existing gaps that are inhibiting the creation of different technologies in India? Somewhere, somehow, we are not able to build, because for following the age-old notion that is people are more comfortable with the traditional methods of treatment as opposed to adopting newer technologies such as home dialysis or hemodiafiltration technologies or portable health applications for kidney care. So are there these sort of gaps that you feel that also exist other than those that Dr. Arpita has pointed out?
So thank you. I fully agree with Dr. Vishwanath and Dr. Arpita. We are a country now with a burden of CKD being huge, and my understanding presently is more than 5 lakh new patients reach end stage per year. One of the things that we have successfully done is penetrate into the remote areas, even the taluk levels and the district levels. Accessible dialysis care is now today available. So I think that is the success story of India as far as the dialysis technology is concerned, available at their doorstep. Where we have failed, as my predecessor, both of them have talked, we have not emphasized and maintained the quality of dialysis where we should be. And I believe one of the areas where we can really improve upon, quantity, I think we have no problem with. Quality is where we have to improve, and both of them stressed on one, access to the dialysis centers, water quality there. So these are all part of the technology where we can improve. You may be aware there are areas in the world where a home dialysis, the machine can be connected to the tap water. So I think we should get there. That should be our goal, and it's a long journey, but I think we are on the path. The home dialysis per se, I have around 5 patients on home dialysis in a city of Hyderabad. The uptake has not been that much. One of the barriers being the cost. If a patient who comes to the unit spends around 25,000 rupees per month on the hemodialysis, we have home dialysis, we charge close to 50,000 rupees. So I think the water system innovation or technologically can be made a little more simpler and less expensive. That way we can make home dialysis more accessible to more number of people. This is a good time to discuss peritoneal dialysis because it is a technology which has been available for a long time in our country, but for some reason the market of the peritoneal dialysis has not improved. In fact, there has been a degrowth. And it is like a home dialysis, though it is not a home hemodialysis. I believe the obstacles there or the challenges there also have to be addressed. Thank you.
Thank you so much, Dr. Rajshekhar, for pointing out those obstacles and challenges that are still persisting in the way of adopting hemodiafiltration very widely in the country. There are other barriers also being highlighted, such as the out-of-pocket expenditure that patients feel, and that is why they are not able to avail such facilities that are being provided by the government. So, Dr. Manjari, can you please touch upon how the quality of the dialysis can be improved? As Dr. Rajshekhar said, that focusing on the quality of water is one such aspect. Another aspect is also potentially in future making dialysis portable so that it can reach the homes of people conveniently and can provide better easy care. So any other points that you would want to touch upon that are essential and are a growing necessity for kidney care and CKD treatments?
Thank you, Dr. Asawari, IHW Council, and Dr. Reddy's. I do agree that we need to have a lot of innovations regarding the home dialysis. If you see in the West, home dialysis is being carried out, most of the people, they prefer home dialysis because that's a better option of getting the dialysis care. But in India, I think that it's still lagging behind. And firstly, because of the cost, it is quite expensive. And then patients are not willing to go ahead with the home dialysis. They are more comfortable to coming to a center for hemodialysis because there are people to take care of them in the center. Right? There are people to prick them. There are people to look into the alarms of the machines. There are people to, check the blood pressure and everything. But if it's a home dialysis, everything which is done at home, then you need to have a very good setup at home. Obviously, you need to have a care system also, people to follow you, to support you, and also the quality of water, which Sir has rightly mentioned. The quality of water for home dialysis should be very, very good, whereby these patients will not land up any problem later on.
Thank you so much, ma'am. So we are have discussed about home dialysis and kidney transplants. So another emerging technology that are there in CKD treatments is robotic assisted transplants as well, or robotic assisted surgeries. So can we please have Dr. Vishwanath, sir, touch upon this aspect, inform our viewers, which are, normal people, not from medical backgrounds, so that they are also informed on different technological advances that are available in India?
Robotic has come in a big way in the surgical field. I think name a surgery they are trying to do with the robotic transplant. Even transplant they have started doing. Our unit also we are doing. But it is not like robot is going to operate. It is the surgeon who is going to operate with the help of the robot. It is more accurate. And if you can see, your movement hand moves only 180 degrees. Robot moves 360 degrees. So some areas where you cannot reach, probably robotic transplant is helpful. But it is not that everybody needs a robotic surgery. Simple transplant is always a simple surgery. You just make a small opening, connect artery, vein, and ureter. That's simple. So for a robot transplant as such, robotic transplant may not be needed for few specific patients whom we think robotic transplant gives an advantage, like people who are very obese, where we think the regular wound may be a bigger one, it may not heal, it can get infected. Only few indications are there where we use robot for a transplant. If you look at our regular transplant, 80 to 90% of our transplant are regular simple transplant. Few selected patients we do robotic transplant. Of course, with the availability of this, many people come and ask us, can you do robotic transplant? May not be needed actually. It is good surgery, but it may not be needed for all. So my message is, don't think of doing robotic transplant for all the patients. Only selected patients it has advantage. It has its own disadvantage. So few people it helps. So whom we think it is very helpful, we choose and do robotic transplant. And it is again dependent on the surgeon. So he has to be very familiar with doing it. And it also has its own negative implications. So we need to be careful. And transplant surgery is something, especially live transplant and cadaver, we cannot have anything going wrong. So that's the reason usual learning curve will be there. So all these things have to be kept in mind. Few selected patients we have done robotic transplant. We have been doing robotic transplant last 5 to 6 years. Results are excellent. In fact, the advantage of doing robotic transplant is patients can go home early, small incision, the drains can be removed early, the wound heals with a better healing process, and chance of infections are much lesser. And in fact, people have seen even lymphocytes and things like that are much lesser. So it definitely has advantage in select group of patients, has given better results. And of course, it is dependent on the surgeon who does, and they should be familiar with doing it.
So can you also please touch upon how wide the expansion of this technology is there in India? How widely is it adopted or used? And if there are any gaps in this one that need to be addressed and looked upon?
Definitely, anything to do with technology will be expensive. So obviously, somebody has to invest in a robot. A robot is not simple. It is something similar to investing on an MRI and a CT. And many routine surgeries have been done with robotic help, like nephrectomy, or sometimes you have somebody who has a cancer. With robotic nephrectomy, you can do a selective removal of the cancer. Otherwise, you have to remove the whole kidney. So you can do what is called as partial nephrectomy. These things are easier with robotic. And of course, your scars are lesser, recovery period is faster. So that's the reason robotic has been used very much in oncology. Nephrology, we do use for nephrectomy, even both for donor and recipient, we can use for transplant. Nephrectomy makes more sense, especially people who have cancer, where you can do a selective surgery and spare the rest of the kidney. It is called sparing surgery, which you can spare the kidney rather than removing the whole kidney. So even in obstetrics and gynecology, they have used more of robotic surgery. Definitely, it has an advantage in few specific situations. In kidney, probably nephrectomy, partial nephrectomy definitely helps. It helps to do a small selective surgery. And in fact, it's come in a big way in surgical oncology, where you have cancer spread everywhere, or wherever you want to do specific surgery, probably robotic surgery is more beneficial.
Thank you so much, sir. Dr. Arpita, the next question to you would be, as majority of India is suffering from NCDs such as diabetes, and diabetes has close linkage with kidney diseases as well. So when it comes to transplant and caring for kidney diseases, how crucial is it to, make people aware? Those who do not have been detected of kidney diseases, just have hypertension or diabetes, to make them aware about their kidney health checkup, and at what stages or ages in life should compulsory kidney health checkups be advised and should be a part of a regular protocol of the medical diagnosis, so that early detection is possible, so that we are not progressing onto the late stage or end stage of kidney diseases and then coming to the doctor. So, ma'am, your views.
Thank you, Dr. Savan, for a question which is very pertinent for India. So we have a large population of diabetes and hypertension, and all these government, I am part of a government institute and involved in the policy making. So I feel that we can tackle these on the same board where we are tackling the non-communicable diseases by government. Their government has started screening for non-communicable diseases. We have to, as nephrologists, as a society, we have to send them the message that at the same table, they should start screening for early screening for the kidney diseases. What people were aware of was the blood creatinine checking. Doctors are aware of is probably blood creatinine checking, but we have identified that urine ACR, even when your creatinine is good enough, because creatinine is a late responder, we can check this urine ACR and we can couple these with a non-communicable disease screening program. That time to time, the diabetic people should have the urine ACR checked and the urea creatinine checked as the duration of diabetes and hypertension is increasing, and making them aware that that is the empowering of the community health workers who are working there. If they start taking data in there, empowering the community health workers with smartphones. It has been looked at Thailand, where they had started doing these some smart apps in their smartphones, and they start keeping data in the community health workers are uploading data to, and you can have at the government level a big AI managed big data management and data splitting system, which can show you what is the magnitude of the problem, how much money you would require for addressing the problem. And at the community health worker level, at every checkpoint, you may remind them of the next guideline of care. That is, when a person is suffering from diabetes for more than certain duration, you must enter into the kidney screening procedure. Hypertension or a family history of some kidney disease, you must prepone your screening so that you can detect the disease earlier and address them. And also we know that this diabetic population, even if when they are not reaching the extreme stage of ESRD and transplant requirement, we lose many of the patients due to cardiovascular diseases. So sensitizing the community health workers, again, for the heart failure symptoms, to take the symptom information, send it to the telecommunication. During this COVID period, one good thing we have learned that we are practicing telenephrology, probably each state is practicing. So connecting the community health workers to the telenephrology sectors in the second care level, district level, or in the tertiary care level, that is the the tertiary hospital, would benefit them quite a lot, and really what problem we were identifying, that the patients are not accessing the healthcare. We are telling that we have all these things in for your facility, but they are not able to reach us. Such is the poverty in socioeconomic aspect and poverty of education. So empowering these community health workers is something which is strong in my mind, and we may go for such advocacy through our society.
Thank you so much for highlighting another very vital points, ma'am, that that these are the requirements that are still there, especially the socio-economic poverty point that you highlighted. My next question is to Dr. Manjari, ma'am. Ma'am, can you please touch upon, as we have seen, that home dialysis option is not really suited for people of, low to middle income backgrounds, as the expenses around home dialysis mechanism is really high. And the telenephrology method that ma'am has pointed out, can you please highlight if this would be able to reach the remote locations and would help in covering the gaps that we are seeing of people not coming to, not even being able to access the given facilities? If we have any remote monitoring system or mobile applications or M-Health softwares like that around renal health that impart not just the education on health diseases, but also somehow is able to connect you to your nearest health specialist or the health facility and facilitate to helping in bridging the gap. If are these options available, or if these are underway in India, can you please touch upon those?
Thank you for a very important question. And as Arpita ma'am has rightly pointed out, during COVID time, obviously, we did a lot of telemedicine, right? But the thing is that telemedicine is only for consultation. Where there are emergency situations, many a times it's very difficult to get the actual picture from the patient. They might just tell you that he is having swelling of the legs, but when the patient comes to us, you may see that the patient is in fluid overload. So there are two different situations. First, the patient should be well versed with the various situations or the complications of chronic kidney disease. And secondly, they should be able to spontaneously or in a very correct way, they should be able to show the picture to the person who's doing the telemedicine. And obviously, another good choice we have, or the option we have, is the sensitizing the local physicians. Once the local physicians know about kidney disease and how to tackle and what are the symptoms, that will be a much easier approach for us. Because to be on telemedicine all the time, it's very difficult. Me working in a government hospital, right, with so many patient load, if I have to sit in the OPD, I have to see about 200 patients a day during each OPD hours. And during the same time, if you have to be on telemedicine all the time, it will be a very difficult situation for us. So in that situation, I think telemedicine is obviously a good option, but it is not the only option. We need to sensitize the local doctors, the local physicians, the other people, and some healthcare workers, where they are, sensitized about the various problems of kidney diseases, its manifestations, signs, symptoms, and the treatment.
Thank you so much, ma'am, for pointing those out. Also would like Dr. Rajshekhar Chakravarti, sir, to please touch upon the need for expansion of facilities for covering end-stage renal diseases for reducing the overall burden of CKD in the country. Sir, you are on mute.
Yeah. To start with the second part of the question, as Dr. Arpita clearly told about the need for regular checking, we need to make the entire population aware and have a policy in place wherein at least the high-risk group, when we say high-risk group, every diabetic in the country, every hypertensive in the country, every person who has got recurrent stone disease, every person who has got recurrent urinary infections, somebody who is obese, also those who have one family member suffering from kidney disease. All of them have to have an annual checkup of, as she mentioned, the urinary protein test and also serum creatinine, along with their diabetes checkup and hypertension checkup. The minute this happens and we are able to label them as CKD stage 1 or 2, it is at that level that the maximum good can be done and we can prevent progression to further stages. And our country cannot afford care of only ESRD. And this is where our resources and awareness should be focused on. Second, the first part of your question was about the expansion of the facilities. So for those who have already progressed to the end stage, India today is capable of offering all the range of treatment modalities: hemodialysis, hemodiafiltration, peritoneal dialysis, and kidney transplantation. And in the kidney transplantation, we have close to 10,000 kidney transplants per year now. Last year, I think we crossed 10,000 in the country. There are live-related transplants and also cadaver transplant and some pockets of unrelated transplants which are increasing in the country. So as a country, we have the wherewithal to take care of whatever is there. But as a community, we cannot afford this end-stage care. Therefore, we have to focus more on the prevention and delaying the progression of CKD.
Thank you so much, sir, for so nicely pointing out all these things that need and our attention and all our focus. And before we come on to the last aspect, there are few common questions that are open questions for discussion to all our panelists. One such is the innovation of artificial implantable kidneys for CKD treatments. So it is an open question for all the panelists. Please, can I have somebody for touching upon and telling us what these are, how these are different from regular kidney transplants?
So as the last speaker, let me continue and then each of us can give in. My understanding is the artificial implantable kidney will not be a reality commercially available thing in the next decade or so. I am aware of certain areas of research happening wherein a miniature filter is being kept inside the body, connecting blood flow from a vessel and then filtering urine into the bladder. So there is one connection to a blood vessel and another connection to the bladder. So as a miniaturized equipment, it is available in certain parts of the country and people are trying. Where we are getting into trouble is the blood, when it enters these filters, is getting clotted and we do not have the wherewithal to anticoagulate blood and prevent clotting inside these miniature devices. So I think it's going to take some more time for these to be readily available across. What I believe will be the next step in our country also is xenotransplantation. When we say xenotransplantation, we are talking of taking kidneys from animals like pigs, which are very close to humans, and then getting over the barrier of rejection in that group. I think that is going to be a reality before the implantable kidney. Other panelists can come in. Thank you.
When we talk about the artificial wearable kidneys, basically, to provide more effective renal replacement therapy to our ESRD patients, the focus is now being shifted from a disease-centered to patient-centered approach. And since your question was on wearable artificial kidney, I just like to throw a few highlights on it. That it is basically a miniaturization of the dialysis process, whereby it can fulfill the following objectives of better portability, patient freedom, there's autonomy of movement, there's better quality of life, and improve overall clinical outcome. So there were two types of artificial wearable kidneys. One was the hemodialysis, then the other one was the peritoneal dialysis. And regarding the wearable human kidney, what they have designed, what the design was that it was a less than 5 kg device. It was, it can be worn as a belt or a vest. And it is battery operated. It requires only 400 ml of sterile water. And the components include a pumping system, a dialysis membrane, dialyzed regenerating system, a battery, and patient monitoring system. And experiments in human trial was conducted in 2016, way back in 2016. And the outcome of the trials were, there were no adverse hemodynamic changes. The target ultrafiltration was achieved and the patient satisfaction rates were reasonable, but it's still yet to see the light of the day. It is still in the, this trial was done in 2016, but yet to be seen. And regarding a wearable artificial kidney for peritoneal dialysis, It also has a carry life system for PD with replacement sorbent cartridges, and recruitment for human trial is going on, but the results are still awaited. So it is being developed, but yet not very available, not very much in the clinical use as well, but will usher a new era in clinical practice, maybe after a few years. But there are a lot of difficulties, a lot of drawback. When we think about the wearable kidney and somebody is wearing that kidney and going out, maybe he's traveling in air. So will the patient pass the metal detector test? If he undergoes a metal detection, the beeps will be there. Where will he have an additional space in that the flight, right, to keep that wearable artificial kidney when he follows? And these are little things, practical. I think from my this is what I was thinking when we were discussing about the wearable artificial kidneys. So these things, practical problems have to be looked into before the wearable artificial kidney is used as a common modality of renal replacement therapy for the ESRD patients.
Thank you, ma'am. Dr. Arpita, your points, ma'am.
I think Dr. Manjari has spoken well about the technical details, and every new research is exciting. When I teach this topic to my students or ask them to write a short note in the exam, it's really nice to look at the explorations of science. But what Dr. Chakravarti has told, it's really far-fetched in the socioeconomic background of India. India has a very large number of affordable and non-affordable both segment. We are that way. We have some overdeveloped and underdeveloped people together. So I don't know for in next decade whether all the barriers of practical use of it would be solved. I think cost will still remain a barrier for India to adopt it in public, but definitely there might be some pockets where it would be utilized.
Dr. Vishwanath, your inputs?
Nothing new to add. Rajshekhar sir has summarized. I believe it is not so simple. It's been there for some time, like 10 years. It's been going on. In fact, many of my patients were telling, sir, I don't want to do transplant. I'll wait for artificial kidney. Then we kept telling them, you don't know when it is going to come. You look at what we have. The only latest one we have is transplant. Beyond that, it's not available for practical usage. So basically, as Madam said, Manjari Madam and Arpita, we are not able to offer to the patient as a practical usage at this point of time. When it will come, it's been going on for 10 years. Will it come in next 2-3 years, or it may take another 10 years? There are a lot of small hitches which they have. Like as Rajshekhar sir said, there is an access problem. You need to be continuously on it is like putting dialysis to the patient continuously. So you'll have anticoagulation problem, blood can clot. As Madam mentioned, it may be difficult to travel. So it is not so simple as it looks, as people think. So it has its own glitches and hitches. So we need to iron out all those things, but it's going to take more time. And maybe easier one is to look at xenotransplant. So maybe take from an animal, or artificially lab-grown kidney may be a better one, so that you don't use any immunosuppressive medicines. So probably that may be earlier than the artificial kidney. If it comes, yes, definitely we can use. And in fact, bioartificial kidney has become more successful in acute setting rather than chronic setting. As of now, for a chronic kidney disease patients, we are not able to offer. If it comes, it will be good. Probably we will have some more free time rather than spending with patients. Somebody is an artificial kidney patients will be on their own. You can see them once in a while. But it has not yet come to the practice now. My suggestion to patients, don't keep waiting for that. I have seen many people becoming sick waiting for artificial kidney, and in fact survival may be at stake. So you take what is available now. As of now, we have availability of dialysis, availability of transplant. So that's the only thing which is available to replace the kidney. That's all we should think of. If it comes to that, definitely we'll offer. I tell our patients, if it comes to that, you will be the first person to offer. So maybe if Rajshekhar sir starts one trial, I'll send patient to sir, sir, please start artificial kidney. So we are all looking for it. We are hopeful that it will come. Hopefully it will come soon.
Thank you so much to all our expert panelists for highlighting this very practical viewpoint on some emerging and technologies that are still underway. But as our topic is on emerging technologies and technological advances on CKD care, with technology, I feel whatever the mind can think of, it can achieve in some amount of time that is required for sure. So on this last aspect of the discussion, I would like all our panelists' views on an ideal world wherein I would want them to describe what the ideal innovation they would want to see that would help in optimizing the quality of care, improving the patient engagement and overall patient journey with CKD. If we could have one such innovation like that in your expert experience, what would you want that to be? Let us start with Dr. Vishwanath.
I would want to do again, see, probably go back to screening. In fact, if you look at Japan, they screen all the children for proteinuria, hematuria, and things like that. So I would want something which we can screen at grassroots level, something like what you do GRBS. If you have some dipstick, and then we have dipstick available, people should use. So we should do that screening at very grassroots levels, and then probably we should have a screening for creatinine, which Rajshekhar sir mentioned. If you have a creatinine, we can compare the kidney number and make sure the GFR is good. So these two simple things which could be used on day-to-day basis. Look for proteinuria, hematuria at a simpler level, grassroots level. Look for creatinine. If some stick is available where something like sugar, you can check creatinine at their home. So probably that will make sense. And then prevention. So I think most of it should we should focus more on prevention, and technology should be used for prevention. In fact, there are some technologies now people are using, like you can use the app to measure the bilirubin level of a child born in a remote village. So something like that we should have for kidney, where you use technology to screen for proteinuria, blood in the urine, and creatinine at a grassroots level. Maybe some app or something like that in future, if it is available, it will probably help us. And then screen the patients, detect them early so that you prevent further damage to the kidney and prevent them from getting into dialysis and transplant. That's what I would like to have.
Thank you. Thank you so much, sir. Dr. Arpita ma'am, your ideal innovation, what would that be to help you?
The most ideal innovation I dream of is never possible, is to flatten out all the poverties from my population, enabling them all to go to school, have square food, have good health education. That's not possible. So let's concentrate on what's possible. So close to my dream, I would think Dr. Vishwanath has rightly highlighted the school health screening and making the family more aware of what their children should eat, what their children, the childhood obesity is now very common. Few years back, I had reported a school health screening where I found a lot of children are having obesity because the food habit has changed quite differently from our time. So the games have disappeared, everything in virtual, and the students are stuck to some computers and mobiles, and they have lost the charm of really being in good health. So all these things may come into that the screening should start at the school health level, which would be enabling the parents also to learn how to live, and parents also to get them a blood sugar pressure checked and coming to the school health interview to tell them that, yes, we parents are free of hypertension and diabetes, so my child is at less risk. And what exactly he said, that we find a lot of IG and nephropathy patients in our country who remain undiagnosed because they have little bit of protein in urine and some undetected microhematuria. They reach us only when they get words on creatinine and require dialysis support. And at that point of time, I don't have to offer them any prevention concept rather than to dialysis. So school health program is a very, very important area where you can sensitize both the child as well as parents. And also what I was talking earlier, that working hard and the community health worker level. not only to overburden them with work, to look at their salary, to look at their, to enable them more with smartphone and apps and how to utilize them. And Dr. Jha was some time back sharing with me that really remarkable what is not expected from community health workers. One pocket of education have made them done this, because many of us are now very useful to you, very used to use the smartphones. So the way they were putting data, the way they were putting the alarms, what Manjari was thinking that whether right picture will come, they are submitting the actual facial picture, the photos, they are submitting the reports, they are asking the right question, that when you are having dyspnea, exertional, nighttime. So it is empowering. No? Whatever you have, you can empower them and can reach to most of your people.
Thank you so much, Dr. Vishwanath and Dr. Arpita, for highlighting the very importance of screening as early as possible, as well as educating for prevention. Such discussions on such fictional discussions will give food to the innovators, so that they can come up with such technologies and get inspired from our thoughts and views, and also our requirements that could be fictional as of now, but in future would be a reality in CKD care for sure. So Dr. Raj Shekhar, what would be your ideal technology, if you could highlight something along the lines of treatment as prevention and awareness has been touched upon already?
So I believe there is not much difference when it comes to the ideal innovation for prevention and treatment, because if you pick up very early, my idea of, I recently read that somebody can tell the blood sugar value of a person just by looking at the watch or the phone without even a drop of blood. So there is a sensor which looks at it. So similarly, we should be able to get the serum creatinine or the level of the kidney function without using a drop of blood, either by the wristwatch or by the phone that is universally available in our country now. For treatment also, when you put these people on treatment, if there is a innovation or a technology wherein on a regular basis these tests can be done without the person going to the lab and giving a sample of blood, I think it will go a long way in making them more compliant to the medications, to the do's and don'ts that we give them as a list. Having said that, the other things that we did touch upon, the quality of dialysis, miniaturizing dialysis, taking it into the home, each one of them will need some innovation in technology to help patients to achieve that. Finally, coming to transplant, we discussed already xenotransplantation. Somebody has demonstrated that it is possible to give a kidney and have no rejection from the pigs. So that would be another great technology to have. Finally, using a lab-grown kidney or a 3D printing of a kidney, which does not need any immunosuppression. So all of them, I think, are what the future is going to hold for us. And I believe they will become realities. It's a matter of time.
Thank you so much, Dr. Shekhar. Dr. Manjari, your ideal technology that you would want to see for CKD care? Ma'am, you are on mute.
The other speakers have already spoken about the technologies that we would like to develop as for treating the patients, nephrology patients. Yes, even I was thinking about mentioning about the wearable devices, like wearing a smartwatch. You know, the smartwatch will obviously give you the ECG tracings. So somewhere can we get something, some indication that this patient is having an underlying CKD? Or if we talk about something like a glucometer, when we test a blood sugar in a glucometer, we want something, a creatinine meter. You put a drop of blood over there and then immediately you can screen the patient, know the kidney status of the patient. And then, yes, the artificial intelligence is there. It is the, in topic now. I don't know how much it will be able to help us. Obviously, it might help us in early detection and interventions. But the most important thing is that education. patient education and people education, and having a syllabus in the school curriculum on kidney health and care. This is very important. Like the other speakers have mentioned about the screening in school. That is very important. At the same time, I'd also like to put in the syllabus about a chapter on kidney health and kidney care.
Thank you so much, ma'am. Now, I would like to request all our expert panelists to give their one message to their audience, to all the people who are watching this Kidney Health Summit today. Let us start with Dr. Vishwanath. Sir, your one message to the audience for keeping themselves and their kidneys healthy.
One message would be check your kidney function. Don't only check your sugar and cholesterol. Don't forget about kidney. Check your kidney function, what we call as kidney number. Now all the labs give what is called as GFR. Once you do creatine, automatically GFR comes. If anything is abnormal, check your kidney function, check your protein, urine protein. If anything is abnormal, seek help. If you are at risk of developing kidney disease, you should do more frequently. If you don't have any risk, then as sir said, do it on a regular basis, maybe as a birthday gift for yourself.
Great. Thank you so much, sir. Dr. Arpita, ma'am, your one message to the audience for keeping themselves healthy.
Whatever my previous colleague had said on top of that, do some exercise, leave smoking, live a healthy lifestyle, eat healthy, stay healthy, check your, if you are a hypertensive or diabetic, don't forget to check your kidney function. If you have a family history of kidney disease, then also you are at risk. So definitely you check the urine protein as well as creatinine, and that's good for all.
Thank you so much, ma'am. Dr. Raj Shekhar, sir, your one message.
So the take-home message is from all of us, kidney disease is a reality in our country and the burden is huge. 17% of the population has it. It means out of every 117 people have. So please see, are you in the risk category? And if so, annually do a test. And once you have a number, follow what your doctor tells you, including the lifestyle modifications and the medications.
Thank you so much, sir. Dr. Manjari, ma'am, your message for the audience.
As nephrologists, we have to be the flag bearers of creating awareness of kidney disease, going out to the community, reach out to the community, involve the social media, involve the television, involve the newspapers, write articles on awareness and reach out to the people.
Thank you so much to all our eminent panelists who have joined with us today. Thank you, Dr. Sidhini Vishwanath. Thank you, Dr. Arpita Roy Chaudhary. Thank you, Dr. Raj Shekhar Chakravarti. And thank you so much, Dr. Manjari Sharma, ma'am. Thank you all for taking out time from your busy schedules for imparting knowledge and your expertise with us and our viewers today on Kidney Health Summit. I hope the discussion for our viewers was as interesting and informative as it was for us, and the points discussed would also grab much needed attention from the government and from the policy aspect for delivering better CKD care in the country. Thank you so much. With that, we will end this session for today, and I would hand over to the session to my colleague, Ms. Riddhi Lakra, who is the assistant editor for IHW TV, for taking a lead in the next session. Over to you.
Thank you all.
Thank you.
Thank you, Dr. Savri, for enlightening session on the chronic kidney diseases, infrastructure, and the role of innovation and technology. We had a very innovative and enlightening session with all our panelists earlier. I thank everyone, and I would request everyone to please continue listening to us on this Kidney Health Summit. Good afternoon, and I welcome you all to the last panel discussion of the Kidney Health Summit. I am Riddhi Lakra, Assistant Editor, IHW.TV. With accelerating environmental degradation as a result of modernization and climate change, is bringing an urgent threat to human health. Environment change can impact kidney health in a variety of ways, such as the water scarcity, global heating, changing biodiversity. Ever increasing industrialization of healthcare has a large carbon footprint, with dialysis being a major contributor. There has been calls for all the stakeholders to adopt new innovations to fight the burden. We also need to develop mitigation and adaptive strategies to combat this challenge. We are here to discuss on the topic environmental changes and kidney diseases, the challenges ahead. To discuss this, we have with us Dr. Narayan Prasad. He is a professor, Department of Nephrology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Rai Bareli Road, Lucknow. We also have with us Dr. Sadanand Busari. Dr. Busari is a senior nephrologist and renal specialist. We also are joined by Dr. Vidya Shankar. He is a lead consultant nephrologist at the CMI Hospital, Bangalore. We also have with us Dr. Dhananjay Agrawal. Dr. Agrawal is a senior professor nephrology, SMS Hospital, Jaipur. And last, we have with us Dr. Jayant K. Hota. Dr. Hota is a senior consultant nephrologist, Apollo Hospitals, New Delhi. I welcome you all for this panel discussion.
Thank you.
Thank you, Nani.
Thank you very much.
Thank you.
Dr. Narayan Prasad, I want to begin with you. My very first question, a very important one. We have been discussing about kidney diseases and a lot of the treatment options for kidney and the problems of the kidney disease in India since morning. So my very first question to you is about what do you think is the major reason in India behind the increasing number of kidney diseases?
Thank you very much, Ridhi, for this excellent question. We all understand that since the morning you might have discussed so many things about the kidney disease. So definitely the very obvious reason of increasing incidence of kidney disease are increasing incidence of the diabetes and in parallel increasing incidence of hypertension. So these are the two major factors. Other than this, there are several other factors also. There are many autoimmune diseases like chronic glomerulonephritis, chronic interstitial nephritis, sometimes some of the cystic kidney diseases that might be this genetic, like autosomal dominant polycystic kidney diseases, and recurrent stone formers. Sometimes what you see that we can modify, the modifiable risk factors like obesity per se can dispose them, some lifestyle factors. And one of the most emerging things which we when doctors or nephrologists are also puzzled with the chronic kidney disease of unknown etiology. So that constitutes about 17% of the all cases of chronic kidney disease. And that is a major challenge where we nephrologists are not able to find out what is the exact cause of this chronic kidney disease. And hence there came out some of the very important factors like the pollution, air pollutions can be the factors, contamination of the water came the factors like some arsenic, cadmium, mercury. Mercury content in the fish has been found very high. So that kind of lead exposures. So there are many other important factors are coming out, emerging, that might be one of the reason of this chronic kidney disease of unknown etiology, like increasing use of the pesticides by farmers in some of the remote areas. Particularly, this data came out from Sri Lankan studies. That might be one of the factors. One of the important factors is that when the farmers work in our fields, under the very humid conditions, they have a lot of sweating, some dehydration, and some clinical kidney injury. That kidney injury does not manifest in the form of the decrease in urine output or rise in the serum creatinine. That is the subtle clinical injury. And obviously this subclinical injury one day turn into the chronic kidney disease and may manifest. So there are several other things going on. Because this one of the emerging factors is definitely the pollution that we should discuss and we should think of.
Thank you, Dr. Van, for explaining that and for an opening to tell so many of the problems. It's actually very shocking to know about that. Most of us are aware, and I hope a lot of our like panelists who are sitting here also would agree with you. Coming to Dr. Busari, also like already Dr. Narayan has explained about the various environmental factors. Also, I would like to ask you some more in deeper form that what are the various and particularly the environmental factors that is influencing the occurrence of kidney diseases in humans. Like he mentioned about the waterborne diseases, he mentioned about the fertilizers which being used in our food. If you could enlighten some more to us.
Yes, I totally agree with Narayan sir, and he has aptly pointed out that besides the normal diabetes and blood pressure issues, the environmental pollution is taking a big toll on not only the kidney but the entire health system, and it's taking a burden on healthcare. So to pinpoint a few things, what I observe as a normal human being, not as a doctor, I would just say that when my grandfather dug a well in his village or in my town, the depth of the well would be around 40 to 50 meters or feet below the ground level. Today, my father, when he dug a well, it went to 100 meters or 100 feet. Today, the groundwater has gone so low that we normally see the bore wells being dug up to 250 feet below the ground. So what has changed is the strata of the water that is we are collecting from 250 feet below the ground level. So the content of the silica and the metals and the different composition that was there in the earlier era in the topmost 50 feet is different from what it is in 250 feet below the ground. So the impurities and the toxic metals and heavy metals that are there in the core of the earth are being dug out today, and we are consuming that water. Second thing is the need and the greed of the farming sector. There is definitely some need, but there is some amount of greed. To have a better productivity, the amount of the pesticides and herbicides are put by the farmers in a higher quantity than they are required to prevent the different infestation, to prevent the doses that are being given to the crops are on the higher side. And these are what we are consuming as general public. We are consuming as a general public, the same is consumed by the farmers. But the farmers are far more exposed because they are spraying it, they are making it, and they are putting it in their soil where they live. So the exposure to the farming community is more as compared to the normal community who consume the fruits and vegetables. So there is something called as CNAC, that is chronic interstitial nephritis in agricultural community. That's an established entity, and we've done a lot of research on that, though we have not published any data as such, but we are collecting data, and we see a lot of farming community getting affected by whatever Narayan sir has said, that it is so subtle, the kidney disease is so subtle that it is missed in the earlier stages of the disease, and patients usually come in advanced stages. Then the work environment. Today, we are all aware of global warming, and we are all aware of the heat issues that we have. In metros or we office goers, white collared people, we go to and switch on the fans and ACs in our room and then in our offices and then peacefully do our work. But for a farmer, he has to go in the farm. He has to toil in the broad daylight, broad sunlight, where he is exposed to lot of heat strokes, and lot of dehydration. This dehydration per se, recurrent dehydration, is also taking a toll on the kidney, And there is no way that these farmers are going to have a better work environment, because they have to work in the broad. We cannot have ACs in the farms and all. So these are the different factors that the farmers and labor class people are going to have a big issue.
Thank you, Dr. Sadanand, for explaining that. And both of you, Dr. Narayan and Dr. Sadanand, have explained like how we are seeing a very huge drastic change in terms of our food consumption, in terms of the production in the farms, like how because of the population increase, that there's a demand for this. And thank you both of you for explaining that. Dr. Vidya Shankar, I want to come to you, sir. As both Dr. Narayan and Sadanand also highlighted about the very fact about the food, so we cannot deny the fact that like our lifestyle has changed. We have adapted to a fast food consumption and much more fancier food. And do you think this is one of the major reasons for the obesity and also introducing insulin resistance problem, and that is leading to the kidney problems here in India?
Yeah, thank you, Mani. So this one, as both the speaker rightly point out, the prevalence of chronic kidney disease in India is increasing because of the multiple factors, the change in the cultural habits, then the change in the lifestyle. So most importantly, we are looking at the factors which are directly implying the implication in the kidney diseases. So we all know that the westernization of our diet, and especially we all know we are present generation and the younger generation are their consumption of the salt has increased, which is to be directly related to the blood pressure. Now there is a historically the salt has been the culprit of even essential hypertension, because naturally the salt is not naturally found. It is made as a preservative, but since there is a lot of cultural habits, we have been now increasing as our taste buds are also getting accustomed to the high salt intake. That is directly causing the blood pressure. That is the hypertension. Nowadays, we are seeing the essential hypertension. If we go to the old textbook, it was between 35 to 55 years where you label them as a essential hypertension. But now we are seeing young hypertensives, even the obesity is also directly implicated. Even we in our clinics will see even in the 30s, late 20s, also they are having hypertension of primary hypertension. That means essential hypertension, because the salt intake is increasing because of the cultural habit, because they are consuming a lot of the packed food, processed food, and especially the meat consumption, the red meat consumption also has increased. Generally what we see in our younger population, and a lot of saturated fats that also adding to this one. So they are having direct implication on the hypertension and proteinuria, and ultimately there is a damage to the kidney. The second is the consumption of the fructose. That is, the fructose is an entity which is artificial sweet. It is a sweetener. It is the fruit sugar which is now predominantly most of this refill packed, or the whatever the juices or the sweetness which are they're using high fructose. High fructose is one of the reasons for the high uric acid, and fructose has got a lot of excess fructose can have high uric acid. It can cause directly, it can increase the certain hormones called vasopressin, which can increase the kidney damage. So there is direct relations. Of course, it doesn't require insulin for the metabolism, so the fructose itself can have because all the fructose get converted into the fat. It's very simple. So one cause of the liver fat deposition is itself fructose. So the excess fructose intake itself could be one reason. And of course, all this obesity, then metabolic syndrome, then the hypertension, all these things are actually one of the important cause of increasing prevalence of chronic kidney disease. And we have seen diabetics for 30 years, 40 years on insulin without having any kidney injury. We have patients coming who are diagnosed diabetic 30, 40 years, they are in 70s, 80s. They don't have any signs of kidney injury. Whereas the newer generation diabetics, where the diagnosis of diabetes is only 5 years or 10 years, but they have remarkable kidney injury, probably because of these environmental factors. So that is very, very important.
Thank you, Dr. Vidishankar, for explaining that. Yes, we do understand that one of the very important thing what we are consuming today is the fast food, which has a lot of salt. And in the with the growth of industrialization, we have also adapted to newer forms of food habits, and we still continue through seeing the Gen Z and both. I mean, even people from a different age group also enjoy eating such food, and that is also indirectly affecting our health. Thank you, Doctor, for explaining that. Dr. Jayant, coming to you, like as you were discussing about the food habits, and with the population increase, there is a lot of demands for different kinds of foods. And as Dr. Narayan also explained, and Dr. Sadanand also highlighted that because of that, there is a constant upgrade in the food production and the agriculture practices. Now that in the name of organic, we are introduced to multiple nephrotoxic agrochemicals through our food, and but as Dr. Sadanand said, that it is only mostly seen in the farmer community. But as you practice in a city, urban city, do you see that such kind of is a burden for us as well? That we are also consuming such kind of vegetables. We are also consuming the much more processed food after the food is grown. So is that also a burden in the future?
Yeah, good afternoon. It's a very nice, kind of session where we're discussing about the effect of environmental factors on the onset of chronic kidney disease. So, as previous speakers rightly pointed out, there are a lot of environmental toxins, which can be, deleterious as far as kidney functions are concerned. And there was one very interesting study, that was published from Sri Lanka, where they have found that the TDS in the water has been the main reasons for the development of significant CKD-U, which Professor Nayan was telling in the first speech. In urban setup where, we are getting a lot of such patients where we really don't know what can be the possible cause of chronic kidney disease, what we blame it to different environmental factors, and what we call it as CKD-U, where the chronic kidney disease is of unknown origin. So one particular factor can be, yes, the presence of a lot of, chemicals and pesticides in the food, which has been grown in a lot of places where there's a lot of use of such chemicals, and those quantities present in our food can be one of the reasons for development of CKD-U in an urban setup. And one more interesting thing which was pointed out by one Sri Lankan study, which has been even accepted by the WHO, is that the presence of TDS in the water, so hard water, especially if it is there and if the TDS is more than 300, so that can be one factor which can lead to CKD-U even in urban setup. Yes, obviously in urban setup, like the previous speaker was telling, we are now, we used to take processed food, and where the the fructose content is very high, the salt content is very high, and couple that with lack of exercise and significant stress on the body because of long hours of work, and inadequate sleep and other things. So these kind of body habits, along with the kind of toxic chemicals what we are consuming. And one more interesting study which was published from I think from Vietnam, was that the air pollution, well, especially in cities where I belong, I belong to Delhi, so especially in cities like Delhi where the air pollution level is very high, there was one study in which they found that every 20 microgram per meter square meter cube increase in the PM 2.5, so there has been increase around 5 to 6% increased chances of developing chronic kidney disease. So you can imagine, I mean, cities like Delhi, Mumbai, and other north Indian cities, where EM 2.5 and PM10, the quantity is so high. I mean, in peak of winter, I remember Delhi's PM 2.5 going beyond 500, sometimes going to the severe category. And you can imagine the impact of those kind of toxic material on our kidney functions. So in urban setup, not only chemical, the pesticides and a lot of chemicals what we are consuming with our daily food, the TDS in the water, the air pollution level, and one more interesting thing is the ambient rise in temperatures. There was one very interesting study, I think from China, where they have found that every 1 degree centigrade rise in ambient temperature is also putting a lot of stress on the kidney function. So that also has been found in one particular study. So all these things are, and coupled with the urban lifestyle where you are consuming a lot of processed food, lack of exercise, and classical sedentary lifestyle. All these are, is a perfect cocktail of the things what can lead to chronic kidney disease.
Thank you, Dr. Jain, for explaining that. Dr. Narayan, coming to you, my next question is, like we see that the water, like I hope a lot of my other panelists also would agree, water is a source of life, and if there is no water, there is a problem, and if there is water contaminated, that's also a problem. And with the changes in the climate change and there's a temperature rise, we also seeing there's a shortage of water that can also lead to dehydration, and in future it might cause kidney problems and kidney stones. So do you think this will be a very big problem in the future?
Yeah, definitely. Water and quality of water, drinkable water, is always a problem. And this problem is there since beginning of the life. So I think as our colleagues has pointed out, Dr. Sadananda has already pointed out, the water level went down even in Chennai, which is just at the seashore. So you can see that is always a problem. Definitely for a person being healthy and the water intake, that is very important to keep your kidney healthy. For the general population who has normal renal functions, who is normotensive, no other problem, water intake should be at least 2 liters of the water, or it is thought that 8 glasses of water should be there every day.
Dr. Narayan, we are not able to hear you.
See, many times water has been found to be polluted with microbials that can cause direct, sometimes diarrhea, dehydration, that we all encountered in our day-to-day practice, that pupils coming with this has taken some water somewhere and has now the diarrhea and got dehydrated, got the kidney injury. So microbial contamination is one. Other than microbial contamination, some of the pollutants are there already. Many of the waste which is disposed in the water, as we all aware about this, when the sea waters are contaminated, sir, now with this, a lot of plastic bottles are there. So mercury levels, arsenic levels, lead levels are found to be in some of the water containing areas. Silica has direct association with the hypertension. And it has, in southern part of the India, one of the study of the borewell study has shown silica level of the water was very high. And that was directly associated with the hypertension incidence in that community. So water is one definitely a great problem, and you cannot about 70% of the content of your body is always the water. So that is important to keep yourself hydrated. That is important. Other important thing which I feel is coming up is air pollution. As Dr. Moda has also told us about the particulate materials. What is this particulate matter? That we measure in terms of the PM, 2.5 PM or 10 PM of the particulate materials. These are all the suspended particles in the air that we all encountered in Delhi regions. Every year there was some period when that comes into the news. So that contains a lot of this nitrous oxide, nitric oxide, sulfate, some of the ammonium, some of the microbials. These are even suspended there. Once we inhale, that cause through the inhalations, it go into the lung tissue, and then it go into the general circulations. And kidney becomes ultimately the culprit because many of these particles are excreted through it. It is very well documented that nanoparticle of the gold, which is inhaled, which was inhaled in animals, and that go through, it enters into the capillary system, it go into the general body circulation, then it is excreted into the kidney, and gold is known toxic. So many of us, you might have this seen many of persons consume some of herbal medicines and some of the medicines which contains gold. Chandi jaisa dimag or gold jaisi kahaniyan we all might have heard of. So, but ultimately what is happening? This gold is toxic to the kidney. Gold is a well-established factor for producing the membranous nephropathy. So it causes ultimately injury. So there are so many heavy particles which we eat directly or indirectly and causing kidney injury. Similarly, many of these toxic inhalants which we inhale that go into the system ultimately, like lead. Those who are working in the lead factory, in the gas factories, in the painting business kind of things, twice contains some of the medical devices. All these contain sometimes this lead, and lead ultimately what happens? Lead nephropathy is a known condition, and chronic exposure of this lead to this lead nephropathy, and that is problematic for all of us. So definitely awareness about this kind of the contamination, particularly the air contamination, water contamination, which is the emerging things, are little, our community is little less aware. And I think through this your medium that needs to spread out that we should think of, we should have the water, that the water should be healthy, clean, and drinkable waters, not contaminated waters. Like we should inhale. Without inhalation, no one can live. But we have to inhale pure oxygenated air, not the contaminated air or air. We should not pollute our system with inhaling this lot of these suspended particles. It has been already established, as Dr. Hutta has pointed out, PM 2.5, particulate material of 2.5 is easily excreted out through the kidney and causes kidney injury. And in one of the studies, it has been shown every time there was additional fall of, if you are living in that conditions, additional fall of the GFR of 0.6 ml per year. So additional GFR decline has been observed in that condition. Similarly, so it is always very important, we should be aware and we should raise awareness about the environmental conditions causing kidney injury, water contamination causing kidney injury. These are important and these messages should go to the health. Thank you.
Thank you, Dr. Prasad, for answering that. Dr. Prasad, just to add on to your question, do you think in future we would also, our body would adapt to such climate conditions, or will we, like in a very, not so much, like in a decade itself, can our body deteriorate and accept that, I mean, we'll have such kidney more problems, or maybe body will adapt to this?
Yeah, see, body always God has given us such a, every organ has some adaptability. You understand, and everyone, our panelists understand that kidney disease manifestations only comes when you have a 90% of the kidney functions are already declined. Then only we have some manifest. What is this? This is all the adaptation. But there is a limitation of the adaptation. And one day this adaptation fails and the symptoms comes in and you will develop the disease. So it is not that we are not able to adopt many of this disease does not appear in a day. There is chronic exposures of these things happening again and again for many years, and then the subtle injury which go on happening again and again. Now this is manifesting in full-blown disease. I'm just giving you an example. You might have read one newspaper in Times of India. One of the lady who are applying cosmetics for many months, and that cosmetics for the shining purposes containing a lot of mercury. Vermilion, which we use to many times for the shining purposes, it is contaminated with mercury. And that exposure of the mercury, although for brightness of sometimes it reduces the melanin pigmentation, so face looks bright. So people used to get it again and again for many months and years. And ultimately, we have reports in the same family, 3 persons coming with the same disease, membranous nephropathy. So these are all established that these heavy and toxic metals are nephrotoxic many times, and we should keep watch over this. Many times, for many of the medicines, which is not a so-called, you can say, there is always a talk about the herbal versus allopathic versus non-allopathic medicines. Many of the non-allopathic medicines, which we thought that will make us strong, but that contains heavy metals, and that heavy metals is causing slow injury to the kidney. So we should have the check balance over everything. Every element is important for our body. There is no doubt. But anything, when in the higher amount used for the many years, that is injurious, and that causes injury to the kidney. Thank you.
Thank you, Dr. Prasad, for explaining that. Dr. Vidya Shankar, I want to continue that same question with you about the water contamination. So we do understand that if the water is reduced, we would also have problems then. But then is another part that a lot of parts in India, like Bihar, has reported that they have like a lot of, in the groundwater level, they have found arsenic, fluoride, and ion contamination. And even in the other parts of Andhra Pradesh also, they have seen that there were increased level of strontium and silica, in the drinking water. So do you think in the future we would also have a lot of kidney problems of such kind because of this? And like, what can be a solution for such water related kidney problems?
Yeah, thank you. As my previous speakers already pointed out that this actually came to picture in when we started diagnosing the CKD of unknown origin and started mapping the population where the prevalence of CKD is higher, and they found certain parts predominantly in Andhra Pradesh, in some parts of Karnataka, now even some parts of Uttar Pradesh, Bihar. So where they found there are the groundwater contamination because as the source was directly implicated, even though scientifically, because very limited studies, they were not able to prove it, but still the content of the silica, strontium, and some of the trace elements which are not normally, as Dr. Sadanand has pointed out, the groundwater quality has changed. So over a period of time, so the prevalence of CKD has also increased. And they have done some studies where they found there is increased amount of protein albumin excretion in this population. So there is a direct relation to the groundwater or water source contamination as a cause of chronic kidney disease. And apart from this trace, this heavy metals and the silica, there could be some pesticide contamination or mycotoxins, like that is also been found to be high, that because especially the fungal toxins like the aflatoxins, there's stored grains, those things also, there could be contamination of groundwater. So there is definitely in this population the prevalence of chronic kidney disease is higher, and they were able to label them as a CKD of unknown origin since few people they have investigated, and they've done some biopsies and a lot of studies since 1993 this been going on. So one important thing is that we all know that this certain population is exposed, and we all know that the cause is the definite contamination or pollution. So it's very important to prove it so that we have a multidisciplinary CKD, a consortium to drive this, whatever that national CKD research, so that the government and the authorities can really look into the issues. And then, because the burden of CKD is very huge, the amount of money spent on dialysis and the transplantation is so high, and most of the times this affects the rural population where the affordability is very low. So it's very important to make a policy to involve all these people, epidemiologists, the nephrologists, the environmental health experts, the basic scientists, the social scientists who are all, especially health economists. So these people should get involved and have a pilot project on looking at these pockets of population where the prevalence is high and there is direct correlation with the these elements which are contaminants. So that definitely is going to have a government policy and have a strict laws in water regulation, especially the excess softening. Nowadays we have a lot of places where in Karnataka we have a lot of places where we get this RO water, which is actually we don't know the effect of this RO water, which is an electrolyte free water, which like a soft water. Its implications also is not known, because certainly the soft water is which is known that it have more cardiac issues. So what is the effect on the kidney, we don't know. So these things has to be really looked into that.
Thank you, Dr. Vidyashankar, for bringing up that point about the importance of water and how we need more studies based on such the usage of water. What are we using in the common places? And I think the municipal and the government, all these organizations need to come together to understand what kind of water being supplied and what kind of there should be a research done to find out about the much more diseases and the implications about using such water. Thank you, doctor, for explaining that. Dr. Sadanand, coming to you, my next question is like, Doctor, we have seen during the past, during the COVID, that we saw such disease can destroy the humankind, and I'm sure that a lot of after COVID, you also might have seen a lot of kidney problems. In the same, like in the future, do you think such bacteria and viruses, if they keep affecting us, can that lead to more of kidney problems? And because we do not understand the pathogen so easily, and whenever there is a new pathogen which is coming, we do not know what it can like it'll affect our kidney or our entire body system. So do you think we need to have more studies based on this, and we need to be prepared for such kind of calamity again?
Definitely. The more and more we are progressing, the nature is hitting back at us in different ways. And there are a lot of studies which have proven that the more we go into deforestation and acquiring land for either agriculture or making human establishments there, the arboviruses and all those viruses that were essentially seen in pyramids and the animals, they are now intruding into the human lives. So there is no stopping that we are going to see many more things like this. And this is going to just escalate with the population explosion that we are heading towards, because the human density and the human behavior and lifestyles have everything taking its toll. The stress is taking its toll and reducing the human immunity is going to go down. And with the newer organisms that the body is not exposed to, it will be vulnerable to those organisms, and it may be susceptible to life-threatening situations in future. Taking on the kidney, as we all know that when HIV came, then we have good medications with HIV now. With HIV, people are having a longer life, but with the longer life now, they are coming up with either HIV-associated nephropathy or crystal-induced nephropathy with HIV medications. So the newer things will come up with new diseases, and we'll have to be on our toes and possibly be ahead of the curve to tackle these issues.
Yes, doctor. Thank you so much for explaining that. And I hope like we understand this fact that consumption of more of medication is also affecting us somewhere. And coming to Dr. Jain, Dr. Jain, I want to ask you this. Like, as we see end of number of environmental factors that will affect the health of people and especially our kidney. Do you think the healthcare industry should become more upgraded to meet such challenges? And how do you think we can fight such problems? Dr. Jayant.
Yeah, see, we are, dealing with a situation where probably we really don't know who our enemy is. They are like multifactorial things, taking from the water to the air quality to a lot of things. So it is like, it has to be a really multidisciplinary approach. I mean, from the government side, from, involving the NGOs, and the healthcare workers as well. So I think people who are working in the field, like the PSM guys, and probably with some involvement of the people who are dealing with such kind of setup where doctors are there, they're trained in kidney disease, they can like the previous speaker was telling, you can pinpoint, yeah, this particular district is having a lot of chronic kidney disease patients where probably the incidence is more than what the general population has. Say, let us say, for example, in general population, we have around 1 in every 10 to 15 patient, every 10 to 15 people, we can expect 1 patient of chronic kidney disease. But if there's a district or if there is a particular, zone where there are more number of chronic kidney disease patients where, you can always tell the government, yes, there might be something wrong with either the water quality or maybe there are a lot of use of insecticides or pesticides in the in the agro products. So probably yes, the healthcare system and especially the nephrologists who are dealing with such kind of unexpected rise in the number of chronic disease patients can is kind of notify the nearest the health executives and take an action so that we can prevent a kind of catastrophe which may otherwise which can be one. There are certain known things. I mean, every government knows. Like for example, I can tell you I'm from Delhi, and I can tell you this issue of stubble burning every winter. Everybody knows there are now n number of studies. Everybody knows. I mean, this is a potential, health hazard, and it is a lot of repercussion as far as our general health and not only kidney health, general is concerned. Everybody knows, every government knows, but still we are not able to kind of see the kind of urgency the government show and the kind of experience we kind of sorted it out, but it is not getting done. So we know probably there has to be some kind of the kind of platform what you are using now, this some kind of platform where general people are made aware that yes, they are going to have a lot of health issues, not only cardiac issues, there can be kidney issues also because of the environmental pollution, and probably they can kind of put on the government where the government has to take some kind of radical measures where we can kind of decrease the air pollution level and decrease the the water pollution. And there are certain belts where people classically call them very infamously known as cancer belt, as you might have heard of. There is a belt in Punjab and adjoining Haryana where they are called as cancer belt because they've been using pesticides and insecticides in so much high level that the basic groundwater water has become contaminated, and there are many young children are also developing a lot of malignancies. So I mean, the healthcare system definitely has to be aware that such kind of things can happen, and especially in the cities like Delhi, where we really see a lot of air pollution, and the groundwater quality at many places is also not up to the mark. So I think yes, the healthcare system, and obviously we have to have some kind of representation in the government so that we can make the government aware that yes, these are the kind of catastrophe we are going to foresee in the future. So that's what it is.
Thank you, Dr. Jan, for explaining that. And I hope we also have more of such initiatives from the government to understand what are the various problems, and if it is shown in our health. So I think we need to have more of research and understanding about the health issues of the kidney, and as you said, highlighted the pollution, the water level, all these things can be easily checked upon. Thank you so much, Dr. Jain. Dr. Narayan, coming to you, my next question, as a public health practitioner, you might have seen a lot of problems very easily at your place, at your ground level, where you're practicing. So how do you think we can fill such gaps in terms of the environment and the kidney care? As a practitioner, what kind of things are you looking upon to the government?
So there are several challenges at the government level and at the level of public also. You can say government also try to make efforts to improve everything day and night, but they are not also able to do. So definitely there are limitations at all parts, but definitely we should try to improve at each step. So awareness is always a problem, and awareness only comes when repeatedly you tell the persons again and again the same thing. So then it comes into the notice. So that is some kind of our society is also. Once you will start telling the same thing again and again, they get registered with them. Like just I'm giving you a very simple example, like the salt intake, as our Dr. Vidya Shankar was telling about. Salt intake is a very important thing, and everyone in the society know that salt intake should be low. Even your lay person will say you should not eat too much of the salt. But we doctors also speak very casually, and the patient also take it very casually. Even hypertensive patients are not very much following this order or suggestions of taking the salt or low salt intake, because it is sometimes becomes very less amount for them to eat the regular food. So, but everyone knows this. So there is a need to emphasize, and how we can emphasize that it is important for you. It is just a poison. Extra salt is a poison. Salt is very important. We have also to explain them. It is very important for the body, but in the amount which maintains your sodium level in the blood. Above and below both are bad, but excessive intake is bad. And there are many demonstrated studies. I am telling you, one of the studies with the 10 patients of only 10% in each crossover study came just 2 years before from, and that has been published in American Journal of Physiology, Renal Physiology. They have shown when they have given extra amount of the salt to the one group of the 10%, there are some markers which is marker of the subclinical kidney injury, like the NGAL and hyperfiltration went up. And if this will continue for many years, definitely these patients, and this is the markers of acute kidney injury. So probably those who are taking the high intake of the salt for many years, definitely this will multiply. Other than this, the hypertension association of this salt intake with the hypertension, so definitely that is going to worsen. And along with that, separate hyperfiltration injury will cause chronic kidney disease. So salt intake is very simple. I am just telling you how to emphasize the patients that no, it is important. Everyone understands that there is we should have the ideal body weight, but sometimes it's very difficult to achieve the ideal body weight. But the importance of the ideal body weight should be emphasized time and again. The disease which is associated with the obesity, that should be highlighted to the patient again and again, and every clinic should be highlighted. And these are the diseases of the obesity. When obesity can cause the subtle ongoing kidney injury, like FSGS is one of the disease which is very commonly associated with this chronic kidney disease. It has been observed the obesity, other than metabolic syndrome and hypertension, it is also associated with some of the cancers also. So there is a disease of many origin of the many disease happens from obesity. So what is important? Important, we have to highlight reducing the body weight. These are the benefits. Maintaining, like the diabetes should be controlled. Every diabetic understands this. But emphasis should be there that how much control of the blood sugar is important, how you are going to monitor. This should be emphasized. And then definitely that also should be, many times there are many newer drugs which are very costlier. And we understand our general population cannot afford this. If you write about these costlier medicines, they are definitely going to stop in the next visit. They are not going to come back with this. So we have to also understand the psyche of the patient. What our patient, how how much he can afford. There are, but there are multiple medicines which are very cheaper also for these people. You know, like the metformin is very cheaper medicine. We can offer, and this is very good medicines. But in early stages of the chronic kidney disease, it works well. If your GFR is up to 30 ml of the GFR, we can use this metformin medicine. So we have to understand, and this should be emphasized time and again to the patient. It should be all over the clinic. It should be from the government level also. Why the government makes the awareness programs about their own programs through the radios, through the televisions. So, and definitely you people are doing the great job by highlighting this, putting it on the YouTube, putting it on the Facebooks and the Stripes, and thousands of the population listens this. And I think this would be the way ahead, where we should emphasize chronic kidney disease is likely to increase by more than 40% by the 2040. So these are the emerging data. And you have rightly pointed out, the dialysis is not the very great therapy. That is also producing itself a lot of waste. Like you can say, dialyzer, every time we have to use and we have to throw out. The dialyzer tubings we have to throw out. 250 liters of the water that go waste. So there are multiple problems associated with this therapy also. So we have to think of where to go. Prevention is the best. When we delay the dialysis by 10 or 15 years, that should be our strategy. So that is the one thing. And then definitely International Society of Nephrology, then Indian Society of Nephrology, we are thinking about the green nephrology. We are trying to make that as much as less content or as much as less contamination we can produce, that will be useful for the society. And better emphasis to give on the organ donation, organ transplantation. And definitely dialysis is life-saving for many of us. So definitely we cannot deny dialysis, but we have to think of it is also producing, it is a part of this environmental contamination. And that is one of the challenges, not only before us, it is also before the government and before the society and our community.
Thank you, Dr. Ram, for explaining that. And I hope we all do agree with you somewhere. And in most of your points that yes, we need to create more awareness about the kidney problems, and government also needs to create awareness, and also along with the other doctors who are working. That's a need of an hour. Thank you, Doctor, for explaining that and bringing up that point. Dr. Sadanand, coming to you, like you as a practitioner, how do you think we can bring the change in terms of the kidney care and the policies by the government, maybe in terms of the taxation on the packaged food, consumption of alcohol and cigarettes in these kinds, and maybe bringing up a more environment-friendly care for the kidney problems?
Yeah. The things that you've asked are like alcohol and smoking, and that I would group into lifestyle changes, and I would take it from a normal level that we talk of to a different level and add a different perspective. If I am a diabetic, I have to avoid sugars. If I am a hypertensive, I have to avoid salt. If I am a smoker, I have to avoid smoking. So this is the lifestyle changes. If I am obese, I have to exercise. This is what our general perception of lifestyle is. Now, let me give you incidents in in my practice, what we came across. Where the place where I practice is an educational hub. There are a lot of people, students, 10th and 12th standard school girls and boys come from different areas and settle here for 2 years with their parents and study here. So there are a lot of coaching classes that are going on in our city, and good quality coaching classes. I have no thing on that. But suddenly, this was before COVID, suddenly there were a spurt of lot of urinary tract infection and urinary stone girls coming to my clinic for consultation. We just first month I did not realize this general urinary tract infection. It's fair. We treated it and we forgot. But when a spurt of children used to come, then we were curious, and what was the reason for this sudden spurt of urinary infections and kidney stones especially in 10th or 12th standard students, especially girls. When we put a questionnaire, we found out that the washroom facilities in these coaching classes are suboptimal, because of which the girls were afraid of drinking a lot of water and avoided going to the washroom. So they had less consumption of water and used to avoid going to the washroom for 8 hours, 7 hours when they were in the coaching classes. So this led to us approaching the coaching classes that you need to improve the facility of washrooms. So after that, 2 or 3 good coaching classes did adapt to that, and the incidence in those coaching classes went down. So these are the changes in the lifestyle of in general things that we can do. Second thing I would change that can be brought about is lifestyle change, is the value system that we have and we are progressing to. We see that the Western world is looking to India on the value system. There was a recent article by the European Prime Minister that India, how does it cope up with those living relationship and marriage system is dying and all. So we have to bring up our value systems. Why we are not able to, especially this is not does not relate to only dialysis, but what I see in my practice is number of people who are dying early or not opting for dialysis, even if it is free, is because there is no caregiver. The husband and wife live in a village. Their studied son has gone to greener pastures, either in metros or US or somewhere else. So the husband wife is alone. When the husband is having dialysis, needs dialysis, the wife cannot take her alone, and there is a caregiver fatigue. So we have to change our value system from nuclear family to a joint family. We have to go back to it. This is the lifestyle change that we need to make. We are separating from our siblings, from our parents because of our comfort. I need my freedom, I need my space. But eventually that is taking a toll on the health, because the caregiver over a period of time gets bored with it. He gets caregiver fatigue. I cannot take it anymore. So there is a patient depression coming in, and there is a caregiver depression that's coming in. So this value system has to change. So these are minimal changes that we should do in our lifestyle. And as Narayan sir has already pointed out, and also Vidya Shankar sir has already said, that it has to be interdisciplinary. That we as a team, when we think of a team, then we take team as more than 2 members. So if 500 nephrologists are coming together and in a meeting in a conference and discussing about higher education and whatever newer aspects, but I think as we should also call in geologists, environmentalists in our conferences. We should go in the conferences that they have, so that the interdisciplinary effect can be more highlighted and we can have a more teamwork is interdisciplinary. And secondly, sir has said that we should encourage government, public-private entrepreneurship, or PPP, that is called as public-private partnership, to address all this issue. Everybody has limitations, as Narayan sir has already said, that the private have their own limitation, government has its own limitation. But when they go into partnership, they can eliminate most of the limitations that, and then take the things, healthcare, to a next level. That's what I feel we should be doing.
Yes, Dr. Sadanand, thank you so much for that. And we hope, yes, we need such kind of collaborations with the government and the private sectors. And as you from the nephrologist community also can come together in creating awareness amongst people, and also creating education about a healthy kidney we can have. Dr. Vidya Shankar, coming to you. Like always, we are closing this. Just another question to add on. Dr. Narayan also highlighted this earlier about the medical waste. So there are studies that the medical waste is one of the biggest reasons for the environmental pollution, and the number of people undergoing dialysis every day is also contributing to this environmental pollution. Do you think we need to bring more sustainable technologies in the kidney care system to avoid the future of such less and a good like a green nephrology, what he explained?
Yeah, as Dr. Narayan sir already has mentioned about the the dialysis waste in terms of either the say that is the plastics which are disposable waste, and the water which is probably source, and then the contamination definitely is going to happen. So the as I said, promoting more organ transplantation or shifting them to the like peritoneal dialysis, because hemodialysis involves a lot of water. Then the patients will be traveling and they're definitely using the vehicle. So there are some studies where they've demonstrated that those things are going to contribute for the air pollution, global warming, all the things, especially when the people are commuting long distances. So those things, when the usage of these vehicles are less, or when the usage of these consumables itself is less, then definitely the contribution to the whatever that toxins to the environment will definitely go down. So promoting organ transplantation, then the probably in future, we don't know, next 10 years down the line, 15 years, 20 years, we might have something like artificial kidney. People may not have go to the dialysis center, maybe 20 years, 50 years down the line. Then that is the way ahead. And definitely, I think we should look at as much as possible reducing this whatever that contaminants, environmental contaminants, so that the other people are protected.
Thank you so much, Dr. Vidya Shankar. Dr. Jayant, coming to you, my last question to you, one message for the people, like on kidney care, and how can we save it from all the external factors, though the environmental factors are such that we cannot avoid it, but to an extent, yes, we can also start doing something for our good, healthy kidney.
So, I want Mahatma Gandhi, be the change you want to see in the world. So whatever bit you can do, for example, you can decrease the stubble burning. If you're a farmer, you can decrease the use of pesticide. If you're a farmer, if you're an urban dweller, then avoid smoking, and take a very healthy lifestyle. Do some early morning jogging, cycling, whatever, swimming you can do. Decrease your unnecessary calorie intake, especially the processed food, no junk food, and good sleep, and taking plenty of clean water as far as possible. So I mean, all these things, I mean, in healthy lifestyle is what we can we can always do, and that is what is required for prevention of any kind of chronic kidney disease. If somebody is diabetic, one has to take care of the blood sugar. If somebody is hypertensive, one has to take care of the blood pressure. Unnecessary consumption of extra salt has to be avoided. Salt should be consumed only bare, around 4 to 5 grams a day, and no extra unnecessary consumption of sugary drinks or very salty food, and regular exercise, and avoidance of over-the-counter medications. That is the use of pantoprazole and proton pump inhibitors in developing chronic kidney. So one should not be consuming proton pump inhibitors, omeprazole, pantoprazole kind of drugs unnecessarily, unless it is prescribed by somebody, a gastroenterologist or somebody who is prescribed somebody, then someone can take these drugs. Similarly, painkillers also over-the-counter drugs. Many times people have headaches or something, and they will go to the counter, and they will get a pill to decrease the headache. Those medications can ultimately also and there are a number of other alternative medications, like for example, when Dr. Nayan was telling, containing gold was So, I mean, everybody has to kind of, in a way, we should have a healthy society. We should, take care of ourselves. We should have healthy style, and not try who have got power, so that we can, kind of decrease the air pollution, and we can give what to, and this is what it is. Thank you.
Thank you so much, Dr. Jayant, for this and giving a very good conclusion for our panel discussion. Coming to the end to our panel discussion, I would like to thank all our panelists who have joined us, Dr. Sadanand, Dr. Vidya Shankar, Dr. Narayan, and Dr. Jayant for joining us and talking about the very important part of the kidney care, what we are talking about, and how it is related to the environment. And we can all do like we can see a good future in terms of maybe we have a very good technology that we start reducing, come up with more sustainable options for the kidney care. Thank you everyone for joining, and on behalf of the IHW Council, I would like to thank all the speakers of today at the Kidney Health Summit for addressing the rising epidemic of the chronic kidney disease in India. Discussing this would obviously bring a change in us, and we all start living a good and a healthy lifestyle. And on behalf of the IHW Council, I would also like to thank Dr. Reddy's for taking this initiative, and our associate partner, Apollo Hospitals. Thank you, everyone. Have a good day.
Thank you so much.
Thank you. Thank you.
Thank you.